Hi, I'm Steve Charles. I'm a vitreoretinal surgeon in Memphis, Tennessee, and I've been working with Orbis for some 30 years with all three of the airplanes, and I'm delighted to participate via this wonderful vehicle of CyberSight. I want to welcome Hunter Cherwick back to Orbis plane and the Orbis enterprise, and we're so delighted to have this opportunity. I'm going to talk today about everything from straightforward retinal attachment to the most complex, giant breaks and PVR, and sort of a cohesive approach to that. There's several themes that I want to cover. In the first section, the core theme is that there's too much scleral buckling going on. We have a cataract surgery community that produces patients that have very little refractive error, very little pain, no ptosis, no strabismus, and we cannot accomplish that with a scleral buckle. And yet, numerous people use ridiculous terminology like, it's the gold standard, we've always done it, it works for me. And they make comments like, well, of course, vitrectomy causes cataract. Not true, not true. Vitrectomy causes progression of pre-existing cataracts. It's my strong view that vitreoretinal surgery should emulate the type of experience that today's refractive cataract patients have, or even standard non-refractive cataract surgery. There's also a notion of those who have moved to vitrectomy instead of buckling, or are starting to eliminate buckling combined with vitrectomy, that, oh, well, if it's a tough case like PVR or traction attachment, you must use a suture 20 gauge or you must use 23. Simply not true. 25 gauge and 27 gauge vitrectomy are optimal for everything from straightforward rhegmatogenous retinal attachment to giant breaks and PVR. There's no need to make larger wounds or somehow revert to older 20 gauge suture technology simply because it's a more complex retinal attachment. I am absolutely unaware of any data to support that adding a buckle to a vitrectomy improves outcomes. Even numerous experts in the field use phrases like, well, it supports the vitreous space, or I just feel more comfortable. I've always done it that way. I do numerous PVR re-ops for other surgeons, and very commonly the PVR and the retinal breaks are posterior to a very broad encircling buckle. So what does the patient want? The patient wants a white, pain-free eye without sutures. They want no surgically induced refractive error. They want no double vision. And they want a procedure that can last 30, maybe 45 minutes under local, not 2 and 3 hour, 4 hour procedures that I see many vitreoretinal surgeons doing. So again, let's move forward to 25, 27 gauge minimal invasive vitrectomy and advance our techniques so that we can repair retinal attachments without adding a buckle or without doing a buckle. What about the advantages of 25 and 27 over 23? There are no disadvantages except this tool flex issue we'll all address. But what are the advantages? There's less pulsatile vitreoretinal traction. It's not just about less wound leaks. It's not just about easier access to small spaces because the tip's smaller. It's not just about more comfortable, all of which we've proven in randomized trials. It's about the fluidics being better, not worse. We had an era of about 5 or 6, 7, 8 years where people said, oh, well, 23 gauge is better because it has higher flow rates. And they use terms that are simply inappropriate from a physics perspective, like flow efficiency. There is no such thing as flow efficiency. Those are separate terms. There's flow rates, which is a number like cc's per minute. And there's efficiency, which is how much material, vitreous and tissue that you remove per unit of infusion fluid. And that has nothing to do with the machine. That has to do with technique. So let's move forward to some of the issues. With respect to vitrectomy, what are the success rates of primary rhegmatogenous retinal attachment? They've been reported as low as 75%, but good surgeons are achieving roughly 90%. Once again, there's this notion that it causes cataract, and therefore phaco-vit is excessively done worldwide. There are numerous surgeons believe that if you're 20 years old and they decide to use vitrectomy to repair attachment, they've got to do phaco and remove your lens. Patients like to accommodate. They can accommodate till they're 40 years old or so. There's zero evidence that you induce cataract when you use today's small fluid volumes to go through the eye and today's advanced infusion fluids like BSS+. The incidence of endophthalmitis is extremely low. I've had 3 cases and now 38,000 vitrectomies. The last one was 25 years ago, and this was a patient that refused any antibiotics subconjunctivally after the procedure. The other two were diabetics. Then in retrospect, I probably shouldn't have operated because they had systemic infections. But what are the buccal complications? I hear people who advocate buccal, who in my view are living in the past, say, well, you know, I never seen any of these complications. They're not looking because they're there. If you encircle, you're going to get induced myopia, and you're not going to be able to predict it or measure it. So let's assume the patient's had LASIK or is an effective contact lens wearer, and then you throw a buccal around the eye, as people say. You encircle the eye, and now they've induced somewhere between 2 and 4 diopters of myopia. They're not happy. They've had cataract surgery. Some effort's been made by the cataract surgery to get the refractive outcomes optimally, either monovision or hopefully your distance correction. And then the patient gets a detachment, which occurs after roughly 1% of all cataract operations. And now the surgeon elects to throw a band around the eye, encircle the eye, and induces myopia. Is there data to support induced myopia? Yes, there is. The late Ron Michaels and his fellow at the time sent all the patients and he was an elegant buckler, sent all the patients to the Wilmer strabismus clinic and had a really careful refraction pre-op and post-op. Average 2.75 diopters of induced myopia. What about ptosis? I can commonly walk in a room and say, oh, have you had a scleral buckle in your right eye? Oh, yes, I have. Why? Because they've got a little ptosis. And my colleague Chris Fleming, who's an ophthalmic plastic surgeon that's worked with Orbis quite a bit, tells me it's probably damage to the levator aponeurosis. What about strabismus? Again, the late Ron Michaels, back in the late 80s, and I think in 1990 possibly, sent all the patients to the Wilmer strabismus clinic and had their forias and tropias measured. 50%, he was, again, a very meticulous scleral buckler, very careful with the tissue. 50% of the patients had increased forias and tropias. Patients are not happy with double vision. Today, we learn more, there's more and more emphasis on ocular surface disorder, sorry for the spelling error, and we've learned that ocular surface disorders are not just about discomfort, they're about a visual disturbance because the first optical element in your eye is the tear film. So I noticed that many scleral bucklers will put one suture at 3 and one at 9 and pull the conjunctiva up so there's a ridge or even overlapping the peripheral cornea. That disrupts the tear film and is going to cause Delin and cause discomfort and cause blurred vision. Persistent subretinal fluid has been shown to be more common in scleral buckling cases than it is in vitrectomy cases. Buccal intrusion, infection all occur. I've removed many buckles over the years, some that I put in the earlier years. I haven't done a buckle in 12 years. Others put in more recently by others. So with all careful technique of covering the conjunctiva, covering the buckle with not just conjunctiva, but with Tenon's capsule, suturing it properly, being careful to properly imprecate the buckle, there are still extrusion rates. Why? Because the tension on the sutures causes them to cut or cheese wire through the sclera, particularly in Marfan syndrome or myops with thin sclera. When the buckle then makes a convexity in the conjunctiva, again, the tear film is disturbed and they develop a Delin over the surface of the buckle, causing the patient to have an extrusion or an infection, particularly if it's a sponge. Retinal incarceration occurs up to 5% of patients with conventional drainage. That is not good, not to have retina incarcerated in a drain site. And there's also bleeding that occur at the cut down drainage site. But if you have a large detachment and you try to do it in a non-drainage, you have the problem of elevated pressure. Again, vit buckles, what are the problems? Longer operating times, all the issues and a higher incidence of the use of general anesthesia, which increases morbidity, potentially even mortality, and certainly cost and discomfort. And again, there's no evidence that adding a buckle to vitrectomy improves outcomes, even though numerous very experienced surgeons remain advocates, even though I'm trying to push our whole community of vitreoretinal surgeons in the other direction. So what are some of the enabling technologies and techniques that allow us to get rid of the scleral buckle and repair these patients with retinal detachment with vitrectomy alone? I've alluded to 25 and 27 gauge vitrectomy, but much higher cutting rates make a difference as well. We're now in the 7,500 to 10,000 cuts per minute, and we actually have FDA approval on the language reduced pulsatile vitreoretinal traction. That's a big deal. Fluidics used to take up to 2 seconds to respond to a foot pedal command. Now they're in the 50 millisecond range. We now have sutureless vitrectomy techniques, both in 27 and 25. Wide-angle viewing is essential. Rubens Belfort first introduced contact-based wide-angle viewing. Manfred Spitsness first introduced the non-contact. So now we have both various wide-angle contact lenses, as well as Biome and Resight and IBUS and other non-contact viewing systems. I have been historically a big advocate of contact-based, but yet 70 to 80% of the surgeons use non-contact viewing. I now have revisited that and beginning to combine the use of contact lenses and the non-contact systems as advocated by several of our colleagues in Japan. And I emphasize once again this notion that de novo cataract is not caused by vitrectomy when you use appropriate infusion fluids like BSS Plus and keep your operating times and therefore fluid throughput in the eye reasonable. If you put a liter of fluid through the eye, you can get a posterior subcap, but not nuclear sclerosis. Well, why do patients get cataract? Why do they get nuclear sclerosis advancement after vitrectomy? That occurs because, as Nancy Holtkamp has shown, when you remove the vitreous, Einar Stephenson has taught us that you reduce the viscosity about 900-fold, and therefore diffusion of oxygen, think Fick-Starling principle, can occur at a greater rate. And Nancy Holtkamp has shown that the partial pressure of oxygen after vitrectomy permanently increases by about 12 millimeters of mercury, and nuclear sclerotic cataracts are known to be an oxidative reaction. But if you have no nuclear sclerosis, it doesn't produce it. I have numerous patients, hundreds and hundreds of patients that are 20 years, even 30 years out from vitrectomy that still have a clear lens. What's the trick? They were 18 years old, 20 years old, 30 years old, and had a clear lens when we started. And so we have to get rid of this notion that, well, vitrectomy always causes cataract, therefore I do buckles. I've heard it 1,000 times on the podium. It's wrong. Put it behind us. I'm not going to review these references, but I want to make the point that, yes, I've done 38,000 vitrectomies, but that doesn't make me an expert on everything. So I've reviewed carefully the literature, looking at the success rates and looking at these various complications. And there's quite a few papers in the literature to support vitrectomy repair. There's a wonderful paper by Pericles Brasilikos from Greece, who trained with Don DeBico at Cornell. Elegant paper showing slightly higher success rates with prior vitrectomy. The paper from a multi-author, multi-center study from Europe that purported to show that buckles were better than vitrectomy in some instances was a very flawed design where the doctors could change techniques, and that paper's often referenced, but in my view, in error. If you look at specific complications, the papers are out there. Many years ago, Fison published this, as you see, 311 patients. Papers on extrusion are out there, infection and requiring explantation of the buckle. And again, there's this Michael Smitty paper I alluded to about the 2.75 diopters of myopic shift. I happen to use the Alcon Constellation Vision System. I use the standard endo illuminator. I don't have a problem with the chandelier, although it is another wound. Of course, I'm careful to make scleral tunnel sclerotomies, which many refer to as bevel, which is inappropriate terminology. As I said, I'm transitioning from using contact-based wide angle to now using non-contact viewing combined with a contact lens, an idea that came from our colleagues in Japan. The crucial elements are, one, never pull back a cutter while the cutter's operating. If vacuum is applied, don't pull back. There's too much aggressive PVD creation with induction of retinal tears, and we'll talk about that more in a moment. It is absolutely essential not only to excise the flap of horseshoe tears, but to remove the vitreous anterior to all of the retinal breaks. That obviously means it's a little more peripheral, and one has to be careful not to bump the lens in a clear lens eye. But again, we must try to remove the vitreous 360. Sometimes scleral depression could be very helpful there, but often if you use proper wide-angle visualization, you can do an excellent peripheral vitrectomy without the need for scleral depression. What are the options to reattach the retina? In standard rhegmatogenous retinal attachment without giant breaks, without PVR, I normally do not use liquid perfluorocarbon or perfluorocarbon liquids unless there's fogging of the IOL because there's been a YAG laser capsulectomy. When you do a YAG laser and you disrupt the anterior face, now the air bubble in the vitreous cavity can have contact with the lens. Of course, silicone lenses have a lower index of refraction. They're thicker and therefore a greater thermal mass, and therefore they store cold and causing the condensation to be worse. But the condensation also occurs with PMMA as well as acrylic lenses. It's not limited, as some people think, to silicone IOLs. So in short, I will use PFO to reattach the retina only in the instance of fogging of the IOL, as we just discussed. I'd use confluent laser around the tears, but I never use spots. Why do I use confluent laser? When you have a thermal laser energy that you're using to create thermal energy, so light to create thermal energy, the heat cannot diffuse out of the center of the spot as effectively as it can out of the periphery of the spot that you create. So in short, every laser spot is much hotter in the middle or in the center than it is on the periphery. But if you move the laser while it's being applied, you smear it, if you will, so now there's a uniformity to burn. If you use spots, you have two choices. You can overlap them, in which case it's too hot in the overlapped area, the burn is too intensive, or to make a term up, you can underlap them, in which case there's a gap in between so that subretinal fluid can travel through. So in short, so-called painting, well, a much better term is confluent laser burns, are far preferable, and I've always used that. And they need to be relatively light burns. You don't want to cause full thickness necrosis of the retina or excessive inflammation. If I use gas, I no longer use C3F8. It's simply too problematic for the patients to have bubbles lasting 3 to 4 weeks. So I always use SF6. Although it's off-label in the United States, and it certainly can be used, I leave not fluorinated silicones, not Denseron 68, not oxane, but PFO, the N-perfluorooctane alkynes for fluoron. I leave it in for 2 weeks for inferior detachments. I have a series dating back over 20 years now, hundreds and hundreds of patients, approximating 1,000 now. It is absolutely, unequivocally not toxic. It has 2 issues. 3. 1, you got to remove it 2 weeks out. 2, residual bubbles must be removed. And 3, some patients have transient inflammation that goes away, but we'll talk more about that later. Wide-angle illumination is important, but there's a bit of a trade-off here. If you have too wide-angle, and you have an IOL in the eye, there tends to be more glare because of this backscatter. So I'm not a big fan of the bullet or chandeliers for routine cases. I normally use the standard illuminator so that I can do focal, specular, and retro illumination. What do I mean by specular? That's the way you inspect the surface of something shiny like an automobile to make sure there's not some little defects. And that's the best way I can describe it. And that's the way you can find rather transparent membranes on the retinal surface, or even find subtle areas of subretinal fluid you might have missed with wide-angle illumination. So instead of illuminating everything like a fog like high beams in your car, you want to have a bit of a narrower beam that you can move around and use retro illumination, bouncing light off the vitreous cutter to visualize vitreous. And by doing that, it often eliminates the need to use Kinolog or triamcinolone to particulate mark the vitreous. So now let's talk about cases that are not routine rhegmatogenous detachments, but cases that are more complicated. And I use the term the reattachment experiment. But I've been asked quite a bit in the last 2 years about when do I do retinectomy. First of all, never do this under saline. Don't do it with infusion fluid eye. Always do retinectomy under air. And don't do it under PFO because you'll have a greater risk of having PFO or liquid perfluorocarbon droplets under the macula, which is not a good thing. So what I routinely do is to do the reattachment experiment. So let's tell what I mean by that. First, in every detachment case, and especially in PBR, you must resect, as shown here, the anterior loop traction. These are radial fibers, radial vitreous fibers that used to be in contact with the retina. They're now contracted because cellular elements cause contraction of these collagen fibers. When people call this peripheral vitreous membranes, there is no such thing. Membranes never grow anterior to the posterior edge of the vitreous space. This is vitreous, not a membrane. And they're not peelable. And to call it shaving is a bit of a misnomer as well. So what really are we talking about? We're talking about there's three sort of orientation of fibers. Fibers that run across the eye, the equator to equator, I call them frontal plane. In PBR, there is no core vitreous. There's a confluence of the anterior and posterior vitreous cortex in this frontal plane. Everybody knows to remove that. But there's no real core anymore. It's a sheet confluence of the anterior and posterior vitreous cortex. Then there are fibers that run in a circle at the posterior edge of the vitreous space. They're highly adherent to the retinal surface and virtually impossible to peel without tearing the retina. But then there's these fibers demonstrated in this graphic from my colleague Byron Wood. And these radial fibers I call anterior loop traction. Those must be resected in every detachment, but clearly in PBR when they're contracted. When cutters were 20 gauge, I had to do this with the scissors. But now that the cutters are 27 or 25 gauge, there's almost invariably enough space where you can get in there. And if you're more peripheral, you're actually less likely to catch retina because the retina, you might say it's on a short leash. There's not as much slack in the retina anterior to the equator. So try to get real anterior. You might have to use scleral depression if there's posterior cortical cataract, posterior capsular cataract, or capsular opacification after cataract surgery. But I don't use scleral depression as much as some other people do because the wide-angle visualization gets around that. What about if there's subretinal proliferation? If it's clear that it tints up the retina, you don't need to make a big retinectomy to remove it, and you certainly don't need any diathermy. What I do is go to the place where the membrane is the band under the retina is the most taut, close the forceps, the max grip forceps, and simply punch through. So I call it punch through retinotomy. Then I back off a little bit, open the forceps, and grasp the membrane. And I use the endoilluminator like a second tool to hold the retina back as I pull this string out from underneath the retina, as depicted here. On occasion, you can pull such a great length of membrane that you can use the endoilluminator like a pulley and pull it over the end of the endoilluminator and get double the pull length. You got to be very careful if these membranes, these bands extend posteriorly to observe the macula. There's a tendency when you make video to look at your instruments and focus on where you're gripping the tissue, but that doesn't matter. It looks pretty in the video, but it isn't. It's not where the safety issues arise. The safety issues arise by not paying attention to the macula. So I have seen cases where people were very proud to pull out a membrane only to realize that the membrane went underneath the macula and they made a tear right in the posterior pole. So keep your eye there. So this sequence here is the most important single thing we can talk about other than elimination of scleral buckles and moving to all 25 and 27 gauge vitrectomy to repair retinal detachments. So what's the sequence about? We all know to do the vitrectomy and eliminate tear in the flaps first in any detachment, rhegmatogenous or rhegmatogenous combined with PVR. Then you start a procedure I developed over 42 years ago, internal drainage of subretinal fluid. People often use a misnomer. They say, I use air to flatten the retina. Air doesn't flatten the retina. You have to drain the fluid out somehow. And so I invented the notion of draining through the retinal brain. So you first initiate draining. Then when the retina stops moving back, you turn on the air, and the air acts as a surface tension agent to kind of seal up where your little drainage cannula goes through the break and to seal up all the additional tears so you don't just recirculate fluid. And some people call that fluid-fluid exchange. I don't know why to call it that. It's internal drainage of subretinal fluid, draining through the break. So then you turn on the air level goes down until it kind of seals up all the breaks, and if it's a rhegmatogenous detachment, it gets attached. But if, as it starts going back, it gets hung up, it won't move anymore, or even a little air bubble appears, that means there's traction. So first inspect and see if there's vitreous traction. And if there is, if you've missed a little vitreous traction, then you can do vitrectomy under air. So implicit in my retinectomy technique, as well as in other complicated settings, is the notion of vitrectomy under air. And we'll generalize that notion as we proceed through this presentation. So let's assume now the retina moved back, you found a little vitreous, you did vitrectomy under air, being careful because the vitreous acts like a bit of a lens element and it can kind of be a bit deceiving about where the tip of your instrument is located. So then you transition to the membrane peeling under air. Often if they're two large bulla side by side, you won't see a little star fold hidden in the valley between the two bulla, the two convexities. So as you continue to drain fluid, the retina starts to go back. If you see a membrane, don't stop and put Kenalog, triamcinolone in the eye or PFO in the eye. Simply peel the membranes under air. The only time you can't do that is if there's IOL fogging or if it's an aphakic eye with striate keratopathy from hypotony or from a corneal laceration repair. But in most instances, you can do it. In those patients, simply go ahead and put oil in the eye and do this work under oil. Carl Kleiss has taught that, and it's an excellent technique. So once again, the retina starts moving back, it hangs up, you do vitrectomy under air. It moves back farther, it hangs up. You peel membrane. It moves back farther, it hangs up. You remove the band. Again, under air. Then and only then do you say, oh, well, the peripheral retina is too contracted. I've eliminated everything on the front of the retina that I can take care of. I've even eliminated a band. I guess I have to cut the retina. So that's the crucial time to do retinectomy. If you do, so this just illustrates in text that sequence. Removal of the frontal plane vitreous, as I described, the confluence, the anterior posterior vitreous cortex, the radial fibers, anterior loop traction, and then forceps membrane peeling, removal of significant subretinal bands accessed by punch-through retinotomy, internal drainage of subretinal fluid, as I said, prior to fluid-air exchange. That's the sequence. You continue the drainage, you research for residual vitreous, residual membrane, residual subretinal. Then you start this incremental retinectomy. What do I mean by incremental? People say, well, how much do you know to do? If you do it under saline, I don't know how much to do. That's why I don't do it under saline. What I do is to cut enough till the retina reattaches. But if it required going 270, I go ahead and take it to 360. Usually it's inferiorly in PVR, and so I tend to carry at least a little bit above the 3 and 9 o'clock meridian. So once the retina is attached, then careful confluent laser to the retinectomy edge and severed large vessels. I can bump up the pressure if there's a bleed from the vessels. I normally don't use diathermy. And again, this eliminates the need for a buckle, and we've discussed the disadvantage of buckle. What are the advantages of retinectomy under air? Well, for one, you do the correct amount of retinectomy. Not too little, not too much. Second, the retina doesn't jump around. It's stabilized. Thirdly, if you choose to do it under PFO, it's real easy. Every meeting I go to, somebody discusses how to remove PFO from under liquid reflorocarbon from under the macula. My answer, don't put it there and you won't have to remove it. And then if there's a bleed with air in the eye, it confines the bleeding to the area of the break. It doesn't diffuse the vitreous cavity and destroy your view. So this shows you the major difference between what Makamer recommended, which was relaxing retinotomy, and what I recommend, which is retinectomy. My retinectomy technique and his circumferential relaxing retinotomy technique were developed at the same time and independently. What's the difference? He just made a circumferential cut and left all the tissue anterior. This results in a higher incidence of anterior segment neovascularization because VEGF is released from this ischemic peripheral retina that's been removed from its blood supply. It results in a higher incidence of hypotony and ptysis because of epiciliary tissue, and I believe it has a higher incidence of PVR recurrence because of seeding of the cells that are stored in this vitreous base area. So in short, it's about retinectomy, not Makamer's technique of relaxing retinotomy. So this then illustrates all these points in text-based fashion in case you didn't catch it when I was talking in front of the slide. This anterior segment neovascularization issue is quite interesting. Harry Flynn talks about donut detachments, and this is from people that do 360 laser, but they make a row posterior to the equator or right at the equator, and then all the retina anterior to that remains detached. That's a bad plan. You've got to get all the retina attached because that peripheral retina, as I've already mentioned, will elaborate a vascular endothelial growth factor VEGF, which results in anterior segment neovascularization. I've had to go in other people's cases and a few of mine where we had the so-called donut detachment and excise all the peripheral retina in order to cause the iris neovascularization to go into remission or regression. So let's generalize this concept of vitrectomy under air. What do I mean? I call that interface vitrectomy. So people say, well, you can't do vitrectomy under oil. Sure you can, but you can't do it in the oil, hence the term interface. So if you're always operating in the vitreous space, the retinal space, the subretinal space, so you can do retinectomy, you can do anterior loop dissection, you can drain subretinal fluid, all the techniques that work under BSS also work under air, oil, or liquid refluorocarbon. Anterior loop removal, forceps membrane peeling, scissor segmentation, delamination that you do in diabetics, punch-through retinotomy for subretinal surgery, retinectomy, all work under air. We all know we can laser retinal breaks under air and drain fluid under air. We do it every day. But many people forget all these other techniques work not just under air, they work under oil or under PFO. I use medium-term PFO for inferior attachments. The patient can sit up, stand up, go to work, drive a car, fly in an airplane, and the PFO stays in 2 weeks. When I put the PFO in after I thought I removed all the vitreous traction, on occasion, I'll see vitreous that's outside and therefore anterior to and peripheral to the PFO bubble. And by carefully sticking the cutter in there, I can remove that and then top up the PFO and remove further traction of the PFO. But I do that once the retina is largely attached, so I'm not going to get PFO under the fovea, and I'm certainly not going to use that PFO technique in PVR. So what are the advantages of interface vitrectomy? 1, improved visualization of residual vitreoretinal traction. 2, subretinal fluid remains stable or decreases as you work, as you remove the traction, instead of the retina moving around and having high mobility of the retina and having fluid accumulate and increase. So this dampening of retinal motion is a big advantage of interface vitrectomy. And as I mentioned earlier, you also confine any bleeding to the retinal surface or right to the interface. So what's the basic technique? Always keep the cutter port in the fluid or in the retina membrane complex outside the interface between the fluid and the surface tensioning. That way you don't lose the PFO or oil, and you don't plug the cutter with oil if you're doing re-ops under oil. So I'm going to speak about this further, but every time I use oil for PVR, if they develop an epimacular membrane or if they develop recurrent PVR, I re-op them with oil in the eye, and it works very, very well. You've got to use max vacuum, 650 millimeters of mercury on the current machines. And again, 25 and even 27 gauge technique works. You can't put a 27 gauge cutter in oil and turn it on and expect it to not plug. And even the 25 plug as well. But that's why you work at the interface. Again, always staying in the aqueous/tissue phase, not in the oil phase in the vitreous cavity. So if you look at the agents, what's different about them? So they're all, by all, I mean air, oil, and heavy liquids, all immiscible in water. Well, two of them float, oil and air, and one of them, PFO, sinks. So that's a specific gravity consideration. The specific gravity of PFO is roughly 1.8. It's nearly twice as heavy. That provides two forms of stabilization of the retina. One is because it's twice as heavy, almost twice as heavy, it actually puts a gravitational force in the retina. It literally presses the retina down. And that helps express subretinal fluid through the retinal breaks. It literally is a gravitational force issue. But then remembering F equal ma, the force equals the mass times the acceleration, there's also what I call inertial stabilization of the retina when you have heavy liquids in place. With air, it's a spring damper, like a shock absorber in your car. But with silicone oil, it provides viscous dampening. And in fact, many shock absorbers in the car have both the compressed gas as well as oil to slow down the oscillations. So what are the clinical scenarios in which I use interface vitrectomy? One is residual vitreoretinal traction noted during fluid air and internal drainage of subretinal fluid. That's the reattachment sequence I just alluded to. Another one is residual vitreoretinal traction noted after the PFO is injected. A third one is excessive movement of the retina during with saline in the eye. If the retina's jumping around during vitrectomy, put air in. It'll keep the eye from jumping around. And if there happens to be an aphakic eye with stride keratopathy or a corneal laceration that obscures the view when air interfaces with the back of the cornea, fill the eye with oil and you'll see better, and you can go ahead and continue to operate with oil in the eye. And then if you put PFO in and the retina starts going back and it hangs up just like I described with air, you can remove some residual traction. And then lastly, and I've already mentioned this, I do all silicone re-ops under oil. But here's what I hear about around the world. People say, well, it's the PVR came back, so I took the oil out, I put PFO in. Well, there was a little PFO into the fovea, and then I put a big buckle around the eye, and it took about 3 hours, and then at the end I put the oil back in. Why? Why do that? Why put the eye through that much trauma and induce inflammation and uveitis and even exacerbate PVR? What do? If you got oil in the eye and you PVR recurrence, peel membrane under oil, do retinectomy under oil, drain the fluid. It takes 2 ports only. Typical reoperation time, 20 minutes. PVR under oil, 20 minutes, maybe 25, instead of these 3 or 4 hour pain-producing procedures. The interfacial tension agents, you can see there the difference in specific gravity and viscosity. The viscosity of water, of course, is 1 centistoke, and oil is either 1 or 5,000 times as much, and PFO is actually less viscous than water. So the most important point in this slide is I've had people say, how do you do PFO with small gauge incisions? It's less viscous than water, not a problem. You can put it in a 30 gauge needle. So what are the advantages of air? It's free. It's easy to inject and remove. It has the highest interfacial tension. What's the disadvantage? As I said, IOL fogging or stride keratopathy. And this makes the spring dampening point of air. What about PFO? 2x inertial dampening, 2x gravitational downforce. It's very easy to inject and remove, less viscous than saline. It's medium cost. Disadvantages, you have to remove residual droplets. The droplets it has modest surface tension, and the little droplets spin off the big bubble. Anytime I leave PFO in for 2 weeks, I fill it all the way up. That's essential to reduce the number of small bubbles. But still, little bubbles get hung up in the zonules, and they'll migrate in the anterior chamber. And we have a nice technique that my partner, Stephen Huddleston, and I reported about how to remove the little droplets in the anterior chamber with 2-needle technique in the office. So the PFO, as I said, supplies both inertial and gravitational dampening of the retina. So if you have PFO in the eye, you can do some removal at the posterior edge. This illustration doesn't quite show that very well, but in short, it is possible to carefully avoid removing the PFO and remove residual traction. And finally, interface vitrectomy with silicone oil. If you're going to leave oil in anyhow, why not see if you can attach the eye under oil, not under air? So here's a common scenario that I've experienced, we all experience. You do vitrectomy, complicated retinal attachment with PVR, you get the retina reattached under air, you laser the brakes, and then you do an air-oil exchange. And the patient comes to the office the next day, gosh, there's a little inferior attachment. What did I do wrong? It was attached at the end of the procedure. What you did wrong is forget, and I've certainly done this more times than I care to remember, is you forget that the surface tension of fluid air is about 70 dynes per centimeter, and with oil, it's about 42. So in short, there's 50% less surface tension with oil than there is with air in the eye. So bear that in mind and make certain that you get rid of all the traction. But if you operate under oil and the retina is attached at the end of the procedure under oil, you're much more likely to see an attached retina the first post-op day. And so here's that viscous dampening point I made before. So these scenarios, I'm sorry, that's a repeat slide. So what about this 2-port technique? If you have a retinal attachment and oil's in the eye, or if you have an epimacular membrane, I put 2 ports in the eye, not 3, no infusion fluid. I don't use tubing connected to the VFC. I simply have 2 ports. If it's an epimacular membrane, and I'm using valve cannulas, you don't remove any oil, and therefore you don't have to add any oil. You don't even have to open the oil and save costs. You simply put the ILM forceps in there and peel the membrane. You got the endoilluminator in one hand, and you've got the forceps in the other hand. Now, if it's PVR and you've got to remove subretinal fluid, then what I do is I remove some of the subretinal fluid under oil. The retina gets, the eye gets a little soft. As the Brits say, I top up the oil with the VFC by taking the cutter out of the port. And of course, the oil doesn't run out like saline would. The eye doesn't get soft. And then I reinflate the eye. Then I remove a little bit more subretinal fluid. It might take 3 or 4 iterations like that. But then in a 2-port technique without infusion tubing even connected, you can re-op a PVR case under oil. It works very nicely. It's a very quiet eye. So here's silicones in the eye, and I'm peeling a starfold under oil, or peeling, in this case, an epimacular membrane. And this shows me, in the right side, topping up the oil at the end. And these are the older type of cannulas depicted there. This medium-term PFO concept I'm very pleased about. As I said, there's a series in Australia and New Zealand started about when I did. They certainly didn't learn it from me, but they do a lot of these cases and are very happy with it. And many people are getting back to me now that they're using this technique and very happy with it. So what are the key elements? Well, as we know, if you're doing even macular hole surgery, that the interaction of the bottom surface, the inferior surface of the bubble with the inferior vitreous can cause an inferior retinal break. This certainly happens in pneumatic retinopexy as well, or just superior detachments. So in short, if you learn that lesson, that if you put something in the eye that floats, you got to be careful to remove all the vitreous inferiorly because of where it interacts with the surface of the bubble. Well, when you put PFO in the eye and leave it for 2 weeks, it sinks. So now you got to be very careful to remove all the vitreous superiorly. So again, the case is remove the vitreous 360 in every retinal detachment case, but not in macular surgery cases. There's excessive peripheral vitreous shaving going on in macular surgery cases. There's simply no reason for it, and it increases the chance of damaging or bumping the lens. So back to this technique of medium-term PFO. Do a vitrectomy. Let's say it's a young myope and they don't have a PVD. Don't pull on the vitreous aggressively and make a PVD and make other breaks. And don't say, oh, well, there's no PVD, I must do a buckle. No, put the PFO in. The retina will slowly attach right before your eyes. It might take 5 minutes for the viscous fluid, the viscous subretinal fluid to come out of the breaks. Occasionally, you have to apply a little vacuum to the breaks. Once the retina is completely attached and you've removed any apparent traction, again, no forceful PVD creation in these young myopes with lattice without a PVD. When you come back in 2 weeks to take the PFO out, it's not just an exchange. You put the cutter in and you will find that they have gently, slowly created PVD during that interval. It's really nice. Why 2 weeks? By then, the laser marks have maximum tensile strength and they're usually pigmented in. If you leave it longer, there's an increasing amount of inflammation from the PFO. It's not toxic. As my ex-fellow Eric Sigler has reported, it's a foreign body reaction. And when you remove it, any little white deposits on the retinal surface or the IOL, it goes away in a couple days without a problem. And again, you've got to remove it in 2 weeks, as I said, and you've got these residual droplets, which can be removed with 2 needles in the office, one to infuse into the anterior chamber from above, and one 27 or 25 gauge, 30 gauge needle inferiorly bevel up right at 6 o'clock, because of course this is heavy liquid, and you can remove the bubbles very carefully in the office, very safely, even in phakic eyes. We've done this many times. Currently, we're over 900 eyes. I give them topical difluprednate for 2 weeks unless they're a steroid responder. And again, we've got this procedure 2 weeks hence to remove the PFO. 360 peripheral vitreous removal has been emphasized over and over again by all of us that do these procedures. So here's the PFO filling. What do I inject? I use the Med1 dual bore cannula. I did not invent it. I don't have a royalty on it. The Med1 cannula allows balanced salt, illustrated here, to achieve egress from the eye, so that you have a normal tensive procedure. You don't have a tiny needle with a leaky port that you're injecting through in order to prevent increasing the intraocular pressure. So this dual bore cannula is a very nice idea. So the so-called up port is the one that allows fluid egress, whereas the distal port, either the side or the tip type, is where the PFO is injected. But how should you do it? You should always have the tip of the cannula, the part where the PFO comes out of the cannula, in contact with the top surface of the bubble. So that means you got to slowly withdraw while observing the interface and raising up the focus in your microscope. That is crucial. Why? If you do that day in, day out, you can make a single bubble. When people say, well, in pneumatic retinopexy, I always have this problem with fish eggs, I make multiple bubbles. You did it wrong. If you lay the patient on their side and you barely put the needle in, you can inject slowly and make a single bubble in a pneumatic retinopexy. Similarly, when you inject PFO, if you stick a short needle in the top part of the eye, you're going to have a zillion droplets, and then you got to wait around for them to coalesce. And if you inject too forcefully, the jet could make a hole in the retina potentially. So the side flow dual bore cannula from Med1 works well, or just inject slowly over the nerve until you get maybe a 2 or 3 millimeter bubble, and then hold the tip of the cannula right in contact with that bubble and withdraw it slowly as the bubble increases in size, and you can create one single bubble. But you gotta really have sharp focus with the microscope. The interface has a very small index of refraction difference, and it's very hard to see. And it's even harder with fluorodecolon than it is with N-perfluorooctane. And so then confluent laser, as depicted here around the break, I know it looks like a smile and somebody that's been drinking a milkshake, but that's the confluent laser notion instead of spots. Get rid of the notion of spots. That's for cryo. So if you've got the PFO in place, as depicted here, and there's some subretinal fluid, you can do one or two things. You can drain it here just by putting a soft tip cannula or a tiny metal cannula through the hole. Or you can extend the break anteriorly a little bit, as depicted here, so you can get rid of the anterior fluid. You've got to get rid of all the fluid, and you've got to be able to laser fluently around all the retinal breaks, of course. And this shows you the cannula that Med1 makes, which again I did not invent. That is the end of my formal presentation. So now we can take any Q&A questions if you have some questions. Well, we don't have any open questions out there. So let's do this over the remaining 10 minutes or so, unless some questions pop up. Let's review what I've talked about. Number one, advance your techniques, challenge yourself to learn to repair every retinal attachment without a buckle. Implicit in that, learn to use medium-term PFO. PFO that stays in the eye 2 weeks for inferior retinal attachments, and what else? Giant breaks. If I have a temporal, a nasal, or an inferior giant break, I put the PFO in, I laser the whole extent of the giant break in a single roll with laser, and I let the patient lay on their back or reclining, and in 2 weeks, I go take the PFO out. I don't do exchange. Now, if they have a severe giant break, then I've got to exchange it for either gas or silicone, mindful of the David Wong technique that you must stay between the PFO liquid interface in the far periphery, so the meniscus is curved upwards, that it's convex, and you don't want to be at the apex of that convexity of the PFO bubble. You want to be at the periphery. So that's the point I want to make there. Let's get this out of the way. So I guess I was talking with my hands. So as the bubble is moving up like so, as you want to, excuse me, as you're exchanging it, here's the PFO bubble, and you're doing a direct exchange of PFO for silicone. You want to stay at the periphery of this convexity, because that's where the little meniscus of subretinal fluid, liquid vitreous, and infusion fluid is accumulated, and you want to remove all that so you won't get slippage of the giant break when you do an exchange. But so think about that. That's the inverse of how you inject PFO. You inject PFO by starting in the optic nerve head, making a small bubble, then withdrawing your cannula with the tip always aligned with the very top surface of the bubble as you grow the bubble and fill it up in a single. So always remember that it's central and on the top of the bubble when you inject, and it's peripheral on the outside edge of the bubble whenever you exchange for either gas or exchange for oil with the PFO. So this medium-term PFO technique I want to bear in mind. Another point we got to emphasize is don't think it's a tough case, therefore I must use 20 gauge. And don't think, well, I've got to support, it's a tough case, it's a PVR, therefore I've got to put a buckle. Change your mindset, try to put that behind you. If you look at it this way, do we today go to the operating room as if we're cataract surgeons and try an intercapsular cataract extraction? If it doesn't work out, switch to phaco? I don't think so. Do you try an RK, and if it doesn't work, then switch to LASIK? I don't think so. So why should you put a buckle in, and then if it doesn't work, go to vitrectomy? Learn to do vitrectomy properly, to get rid of peripheral vitreotraction, to see in the periphery, to do these various exchange techniques, to operate under air, to operate under oil, to operate peripheral to the PFO, and then you've broadened your horizons, you've created a quiet, comfortable eye without refractive error. It's far better for the patients. And then the other point I emphasized early in my talk is the number of patients that I see that they did a phaco bit, but they had a little trouble with the phaco. The pupil came down. Now they had to use iris hooks, which induce inflammation and iris damage. Well, the pupil came down. I couldn't really see the periphery well enough. I had to do such and such. There's so many patients that have, for one, significant refractive error after phaco bit because they don't use the Warren-Hill's knowledge of formulas. They don't use aberrometry. They only use ultrasound to measure axial length instead of optical, low coherence optical means, which are far more precise because they measure from the pigment epithelium. And so we see refractive outcomes that are not good with phaco bit. The second thing we see is compromised vitrectomy because the phaco didn't go exactly as you'd hoped, and therefore the view is compromised. So what I tend to do, staged procedures. Patient presents with 2+ nuclear sclerosis. They need a vitrectomy to repair a macular surgery or retinal attachment. I tell the patient, you're going to need cataract surgery by a cataract surgery expert. That's not me. Let me fix your retina. In about a month, when the retina is stabilized and we're comfortable and the eye's no longer inflamed, a cataract surgeon will do a great job of refractive cataract surgery. On the other hand, the patient needs macular surgery and they've got 3+ NS or a posterior subcap. Cataract surgeon operates, you go back in a couple of weeks and do the macular surgery. Now, if you have a retinal attachment, you can't have a significant view. Instead, if you're a really good phaco surgeon, okay, do phaco bit. But unless you're really good at it, there's no problem with lensectomy. And then once the retina's been attached for a month, do an anterior chamber lens. We've done many, many anterior chamber lenses. I'm very happy with it. I don't think it's absolutely necessary that everybody must have an intraocular lens in their eye in the capsular bag. So we have a question here about an anoretic patient who developed an RD after Ahmed valve surgery for ankle closure. I have not done this, but people have reported using sutures, a couple of sutures that go across the eye at the pupillary plane, where there would be a pupillary plane if there were iris in place, and it held back the oil. Some reliable people reported that. I don't have the reference in my head at the moment, but I think that's an interesting approach to try. I would not recommend this artificial iris approach. Those are very rigid, and I've had the opportunity to operate on a young girl that had this, and it was a huge challenge to do the vitrectomy. Now, what I've done in the anoretic patients is I just tell them don't lay on your back, and I've had good results with that. In a few anoretic patients, I've probably done 15 or 20 anoretic patients over the years. So if you just tell them don't lay on your back to sleep at night, lay on your side or face down, I've had some good results, and you can wait several weeks or months rather and take the oil out at that point. Well, we don't have any other open questions, and we only have about 4 or 5 minutes left. And so, unless there's some more questions, let me provide my email address: scharles@att.net. Feel free to write me and ask me questions or comment on my talk. And I thank you very much for listening.
Dr. Charles, I've just put up on the screen some of the questions that were asked at the time of registration in advance. Right. Maybe just have a quick scan through those to see if there are any relevant questions or topics that you'd like to circle back on.
Sure. When was the last time I did a buckle? 12 years ago. Do I do a vitrectomy for inferior RDs in young faking patients? I do, and I use medium-term PFO. I use a wide-angle contact lens. I currently use the Voke AVI. Excuse me, not the AVI. I use the Voke HRX ACS The only problem I have with it is it fogs if there's high humidity in the room. I never use heavy silicone oil like Oxane or Denser 68. A lot of info, for one, they're not approved in the United States, but for two, my friends in Europe that use them say it causes a lot of inflammation, and I don't do that. It says how, and okay, how do we manage liquid perfluorocarbons under the macula? I take a tiny MVR blade and make a slit over the bubble, a little tiny one, and the PFO will pop out, and then I'll put air in the eye, and that's all you need to do. If the patient reattaches with 360 retinectomy and oil, I'll peel membrane, even do further retinectomy if required. Prognosis total RD with MAC off. The patients have, particularly young people, have wonderful visual outcomes, particularly with vitrectomy. If you do a big buckle, it's a 3-4 hour operation, there's so much inflammation that the visual outcomes are not as good. So I've been very happy with doing vitrectomy only repair with MAC off and getting good visual results. How do I choose between oil, air, or buckle? I never use a buckle, so that one's easy. Oil is for a couple things. One is a patient that can't position at all, a patient that must fly, or PVR. I manage PVR re-ops under oil, as I said, by operating under oil. I don't understand that one. Oh, diplopia after buckles. This is the problem. If someone has a buckle in place, and the buckle's a high buckle in particular, and PVR, and the buckle's extruding or causing strabismus, if you remove the buckle, on occasion the retina will redetach because now the retina is, if you will, contracted in that new configuration. And so that's another okay, then another one is, what percentage of complex RD do I receive at the institution? And when do I operate? I do around 800 vitrectomies a year. Many of those are macular surgery, but many of these are complicated, so-called complex retinal detachments, PVR, giant breaks, diabetic traction attachments. It says, do I have a protocol on when to operate? Yes, instead of rushing, particularly in a re-op setting, let the eye be quiet before you operate. The late Steve Ryan used to talk about the life cycle of PVR. Ron Michaels used to emphasize that as well. Operate on quiet eyes. What technique do I prefer? Giant retinal tears. You got to use PFO. If it's inferior temporal nasal, I leave the PFO in 2 weeks. Never use a buckle in giant tears. Never, never, never. And if it's superior, exchange it very carefully with the David Wong technique I just described. Exchange it for oil or exchange it for gas. Well, now it looks like I've answered all 17 questions and time's up. So thank everyone for listening, and feel free to get in contact with me via email if you have further questions. I'm Steve Charles. I'm a vitreoretinal surgeon in Memphis, Tennessee. I've been involved with Orbis for 30 years and delighted to be able to present in this manner. I've made many Orbis trips, but this is an efficient method of communicating. As all of us know, diabetes is growing in frequency worldwide and prevalence worldwide. It's driven in part by changing diets around the world, and as well as lack of health care in some instances, and therefore the incidence of diabetic vitrectomy and diabetic retinopathy in general is growing. Anti-VEGF therapy has changed it somewhat, but it requires monthly injections. It's more effective than laser, as we know from the DR-CRNet studies. That said, many patients, particularly in developing countries, are unable to have injections every month or have no access to preventative care and present later in the disease with either diabetic vitreous hemorrhage, as we'll discuss, or with the diabetic traction detachment. So let's begin by addressing the indications for vitrectomy. As I mentioned, there's several. Traction retinal detachment has been an indication for a long time. I've probably done more of these than anybody in the world, and it's been a big interest of mine for over 40 years. A big production is often made of patients that have a so-called combined rhegmatageous traction detachment. These are not any more difficult. It just means you have to use gas or occasionally silicone oil, the gas being preferable unless they're very large breaks or multiple breaks. Extramacular traction detachments are often operated by people in the context of macular threatened. I believe this is a mistake. I published with Carl Flynn a paper well over 30 years ago showing the incidence of progression to involve the macula is only 25%, and you get good results if you operate when that happens. So operating on small traction detachments or even medium-sized that don't involve the macula is a mistake, and you subject these patients to unnecessary complications. I've heard the term intraretinal fibrosis. Never happens unless there's retinal necrosis, which is certainly not a part of diabetic retinopathy. Vitreomacular traction syndrome is something that we were largely unaware of until Hill L. Lewis brought it to our attention some years ago, and he referred to it as a taut posterior vitreous cortex, which is certainly the case. But the widespread adoption of OCT, ocular coherence tomography imaging, has radically changed our treatment of these patients because we're able to recognize VMT. For many years, instead of using focal laser for patients that have macular edema, particularly in Japan, and in other Asian countries, they use vitrectomy and laser vitrectomy in lieu of laser as the primary care. Why would vitrectomy alone help diabetic macular edema? Because it increases permanently the oxygen level in the back of the eye. When you remove the vitreous, you increase the viscosity 900-fold, and as Einar Stephenson has taught us, because of the fixed Starling principle, a greater amount of oxygen is allowed to diffuse into the vitreous cavity from areas that are rich in oxygenation to areas that are ischemic, so-called source and sink of this oxygen. So the macula obviously needs to be greater oxygenation, and it's so supplied. Nancy Hokamp was able to show that the partial pressure of oxygen in the vitreous cavity permanently increases by 12 millimeters of mercury after vitrectomy. And again, this is because the diffusion has nothing to do with the infusion fluid or ascorbate depletion. Ascorbate depletion is a result, not the cause. So in short, if there is demonstrable traction on the macula using OCT imaging, then vitrectomy and ILM peeling is appropriate. But doing vitrectomy and ILM peeling for diabetic macular edema without traction is inappropriate. These patients are better treated, as the DRCR-NET has shown, using anti-VEGF compounds, typically on a monthly injection schedule. So here's a typical case with both traction and diabetic macular edema. In this case, the traction is modestly prominent, I would say. So clearly this patient needs anti-VEGF compounds, one in addition to probably vitrectomy. If you look at the submacular space, there's subretinal fluid there. Why would that be? Does that prove there's traction? No, it doesn't. It proves that the amount of leakage of the perifoveal capillary bed is so great that the RPE pump is overcome. Think uveal scleral outflow here, and the pump is simply incapable of keeping up. So when you have large amounts of paramacular capillary bed leakage, often there'll be some subretinal fluid in the macula, and treatment with anti-VEGF compounds will address this. So let's look at some other cases and to see. Now here is a case that has some swelling due to leakage, as you see by these two spots on the right side of your picture, but clearly there's a sort of a plateau appearance to the macula. Yttria or acroplasm, as known, is, in my view, completely inappropriate to use in any of these cases, or in any case, in my opinion. I've never once used Yttria or acroplasm and intend never to use it. The complication rate is significant, and some of the complications based on probably SparkCan6, the interphotoreceptor matrix dissolution and damage to the ellipsoid layer of the photoreceptors is irreversible in some instances, and there's no known way to predict it, no known way to treat it. Some patients get serious fluid under the macula. So in short, don't use aquaplasmin for any of these patients. But in a patient that has this configuration, vitrectomy and ILM peeling is appropriate. This is quite obvious here that there's a low-level traction attachment or advanced vitreomacular traction syndrome, whatever you want to call it. And in this case, because it's the vitreous surface and there's not any epiretinal membrane proliferation, ILM peeling will again work. I strongly urge the surgeons to not make an aggressive PVD in these instances, but to do ILM peeling first. Do a core vitrectomy, but don't grab the vitreous. Many people think there's a linear algorithm in vitrectomy. First you do a core vitrectomy, then you make a PVD, then you deal with the retinal surface. If you do that in patients that have vitreomacular adhesion, you can avulse the macula. That doesn't just happen because of the case. It happens because of bad surgical management. So in short, don't make forceful PVDs in diabetic traction attachment cases or in cases like the vitreomacular traction syndrome here. Please do not make an aggressive PVD. Yes, you must remove the posterior vitreous cortex, but do it in a controlled fashion with scissors if it's a traction attachment, or a controlled fashion with forceps ILM peeling if it's a vitreomacular traction syndrome case, not by pulling on the vitreous with a soft tip cannula with the risky fish strike phenomenon where you move the cannula from side to side. In macular hole cases, not part of this lecture, where you should make a so-called forceful PVD, you pull directly straight back from the disc, not side to side. Side to side motion puts shear force on the vitreous space, increasing the risk of peripheral retinal tears. So here's another case that has both leakage from diabetic macular edema as well as traction. If you look at the second slide, the traction is very, very obvious. And again, I do not recommend use of either pneumatic retinopexy, which is far better than aquaplasmin, and would never recommend aquaplasmin for a case like this. This case needs ILM peeling. What about vitreous hemorrhage indications? It's interesting, in the 44 years I've been doing vitrectomy and 42 years in practice, it's amazing to me how there's a singularity around the question, how long should you wait in a vitreous hemorrhage? Well, this seemingly paramount question is overemphasized. There are many other considerations. For one, is it a thick, dense hemorrhage that's likely to take a long, long time to clear? That's different than a mild hemorrhage when you can even see the retina. Is there an underlying traction attachment based on ultrasound, in which case you must operate? Is there iris neovascularization, in which case you must do vitrectomy and PRP, as well as anti-VEGF therapy to prevent neovascular glaucoma? What's the vision in the other eye? What's the patient's general health? Are they on dialysis? Are they anticoagulated? I'm not concerned about anticoagulation. In my view, it doesn't. If it's patients are anticoagulated for any cataract or retinal procedure, their anticoagulation should be continued. I've published on this with Phil Rosenfeld. It's very, very important to continue their anticoagulation status to protect their life. That said, I've not seen a significant issue of intraocular bleeding that was uncontrollable due to patients being anticoagulated. So let's again go through the list: cataract, glaucoma, medical status, the density of the hemorrhage, clearly the presence of iris neovascularization, traction attachment. All of these drive the decision, the clinical decision making, the judgment on whether to do vitrectomy for a vitreous hemorrhage. It's not just about how long it's been there. Very, very important to think in this manner. The crunch syndrome, or rapid fibrosis from injecting anti-VEGF compounds in people with fluoride neovascularization, has been massively overemphasized. First of all, it wasn't everybody that got an anti-VEGF compound. It was a small cohort of these 100 or so patients reported by Harry Flynn and others. Secondly, in my view, these patients were at risk of blindness from neovascularization of the iris and neovascular glaucoma, from retrolenticular neovascularization, also called, which I first reported, also known as anterior hyaloidal fibrovascular proliferation, and from glial recurrence, which I first reported. So these patients had a bad prognosis regardless. You just changed the nature of their complication. But in fact, I think it's very important for patients that have fluoride neovascularization to receive Avastin or another anti-VEGF agent approximately 3 to 7 days before vitrectomy, so you reduce the risk of bleeding. If you stay in that time window of 3 to 7 days, this rapid cicatricial fibrosis or crunch syndrome is highly unlikely to occur if it occurs at all. And it's very important in anybody that has active neovascularization before or noted during vitrectomy, they should get Avastin at the end of the case to prevent rebound. I believe it's Stanley Chang that first brought this to our attention, or possibly Bob Avery, but this is a very important thing to bear in mind, that you're removing any anti-VEGF compound you injected pre-op at the time of vitrectomy, not intentionally, but because you've, if you will, flushed out the vitreous. And so at the very end of the case, please inject an anti-VEGF compound. Again, very important. Phacovet is massively overemphasized worldwide. In some instances, that's because you can charge for both procedures. In other instances, because people are comfortable with phaco, they like it, they've done a lot of them, and it is, in my opinion, adds complications to many, many cases. First of all, if you do not have nuclear sclerosis, you will not get it from vitrectomy. The idea that vitrectomy always causes cataract is complete and utter nonsense, repeated on the podium by vitreoretinal surgeons worldwide over and over and over again. It is a lie. It's not true. It never happened. I have hundreds and hundreds of patients that are 10, 20 years out from diabetic vitrectomy that have no nuclear sclerosis. What's the trick? They were 20 years old, 30 years old, and had no nuclear sclerosis when we started. On the other hand, if you have 1+ nuclear sclerosis, it will unequivocally progress. I've seen numerous patients that have had a phacovet, and the vitrectomy part, which was the reason to do the procedure, was poorly done because of complications with phaco. The pupil came down, couldn't see the periphery, put in iris hooks and pupil expanders. Now we got fibrin release in the anterior chamber and inflammation post-op. Now we got posterior synechia post-op. And in the developed world, patients demand emetropia. How do you, in a vitreous hemorrhage traction attachment case, figure out axial length accurately? How do you properly do K's and A's in patients like this and produce and use the proper algorithms? Are you able to do torics and get the axis of rotation properly? Absolutely a huge challenge, and that the vast majority of vitreoretinal surgeons are not up to this challenge. So I would strongly urge the listeners, focus on fixing the retina by doing proper vitreoretinal procedures, and don't jump into phacovet in case after case after case. And please don't do phacovet in patients that have a clear lens pre-op, because they're going to get a cataract. It's simply not true. If they have NS, you can certainly think about it. Now, if the patient's very, very ill and you're concerned, or you feel like the transportation logistics, they won't come back, maybe phacovet's appropriate, but put some emphasis into getting the refractive outcomes. Don't use an out-of-date single formula and A-scan axial lengths. If you can get an optical coherence axial length which measures from the pigment of them, it's going to be more accurate, far more accurate in the presence of macular elevation. What about diabetic traction attachment? A pet interest of mine for many, many years. We hear people on the podium who are well-meaning say over and over again, oh, today's cutters are so good, they have higher cutting rates, true. They're small diameter, true. They allow safer removal, therefore you don't need scissors anymore. Completely fallacious. There's those same people, I promise you, when they do difficult tabletop traction attachments, one of two things happen. They either say, oh, this is inoperable, I can't do it, it's a tabletop, it's an end-stage disease, forget about it, or they make 400 retinal breaks and put oil in the eye. If you put oil in a diabetic, plan on having a poor outcome. Try to think of every possible way to not use oil in the diabetic. Why? Oil constrains VEGF, basic fibroblast growth factor, fibrin, fibronectin, and other cytokines and cellular elements, basically Mueller cell glial elements, confines them to the retinal surface, and because the retinal surface is waterproofed, if you will, by the silicone oil, you can't deliver anti-VEGF compounds to the retinal surface, only at the inferior equator where the oil is not in contact with the retina. So this notion that, oh, it's a bad case, I need oil, that's because you're not doing it right. So in short, learn to use scissors instead of saying it's a bad case, making forceful PVDs, making lots of retinal breaks, trying to do everything with a cutter, and then putting oil in. You must learn to use scissors for broad areas of adherence, or you're not going to be able to manage the more difficult cases in a safe manner. This is the most important single thing I could teach today in this diabetic traction attachment. You look at a case like this, if you try to do all this with the cutter, you might be lucky and not make a retinal break, but I doubt it. If you're able to use the scissors carefully, you're able to delaminate. Also remember, I'm the inventor of segmentation delamination. I don't bring that up to brag. I bring it up to make a point. Segmentation means to cut the membrane into pieces. So let's say simplistically to cut it up to release tangential traction in the retina. And it works. And there are many, many cases where we still do segmentation only. And it's solved many, many diabetic traction attachment cases over the years. If you have broad area of adherence, you must use delamination, which allows you, sorry, I got a phone call, I had to hang it up, allows you to remove all the epiretinal membrane. Because we now have this capability with better cutters and better fluidics, as well as scissors to remove all epiretinal membrane, does not mean that epiretinal membrane is cancer, and if you remove all of it, it won't come back. Mockamer had a singularity around the point that vitreous and membrane were kind of like cancer. If you got it all out, it wouldn't come back. And that is absolutely wrong. It's wrong in PVR. It's wrong in the diabetic traction attachments. The reality is that PVR, as well as glial proliferation on the retinal surface, the diabetic traction attachment, is much like a keloid. If you will, nature put it there for a reason. And if you remove it, there's a propensity for it to come back. And so the idea that removal of all of it is the goal, that's wrong too. So even though I invented delamination, which has better outcomes, there's less glial recurrence for reasons I'll discuss in a moment, that doesn't mean that I'm an advocate of removing every bit of epiretinal membrane in every case. So let's discuss a little bit what I'm getting at here. If you leave islands of epiretinal membrane, so-called epicenters, the cut edges of these are vascular and bleed. And it's very common to see a dumbbell-shaped glial reproliferation where fibrin joins if you will, the two cut edges. So it bleeds, a fibrin bridge is formed, glial cells derived from Mueller cells proliferate across that bridge, and now you've got a glial recurrence. Mockamer and Michaels and others denied the existence of this until at meetings I showed them their own post-op pictures where they were different at a month than they were in 6 months, demonstrating this phenomenon of glial recurrence. It's real, and we need to do everything we can to avoid inflammation, to avoid bleeding, to avoid excessive retinopexy and laser, all of which stimulate this keloid-like glial recurrence process. So again, here you see in the lower right-hand corner the OCT showing traction and elevation of the retina, and you can see it on the infratemporal and a smaller area in the supratemporal vessels. If it's present nasally, be careful. Don't remove everything nasal. It's not going to affect central vision. It does secrete VEGF when the retina is elevated, and let's talk about that for a moment. The retina gets the inner part of the retina is oxygenated, of course, by the central retinal artery and its branches and capillary beds, whereas the outer retina is oxygenated by the chorocapillaris, more so in the periphery. But what happens if you have elevated retina? Now the chorocapillaris has to provide all the oxygen. It is the external limiting membrane is not really a membrane, and it's not a barrier to oxygen diffusion. It's all about oxygen pressure, partial pressures of oxygen and oxygen tension gradients. And so if you elevate ischemic retina from the chorocapillaris, it secretes more VEGF. So iris NV, post-diabetic vitrectomy, when you can't see in the eye, is a retinal detachment until proven otherwise. And we saw this a lot in the early years of vitrectomy with inadequate equipment and more common postoperative detachments. So this patient has fluoride neovascularization. If this wasn't treated with pre-op anti-VEGF compounds, you would have massive bleeding before and after surgery. So this case should be treated with Avastin pre-op and vitrectomy performed within 3 to 7 days. The same thing here, that's somewhat cicatricial. You can see a little undercutting of the macula, lamellar macular hole. I have sort of underestimated the need to do ILM peeling in these cases. You can't always peel over the arcades. In fact, you infrequently can because of strong glial adherence. But by peeling the macula, you can get ILM off the macula, you can get rid of macular folds, even these traction attachment cases, and I've only begun to do that in recent years. The notion of core vitrectomy is simply a mistaken notion in the context of diabetic traction attachments. So what should we think about? Cortex has multiple layers. Think cerebral cortex, adrenal cortex, renal cortex, the cortex of the lung, multiple layers. So the term posterior hyaloid face is a misnomer. It's not a face. It has multiple layers. And so why is core vitrectomy misnomer? When you have traction, the vitreous collagen fibers are only 2% by weight or by volume of the vitreous cavity, and all of the collagen is condensed basically into a sheet. So you never see proliferation within the vitreous. Vitreous bands never happen unless a missile went through the eye, some trauma or some parasite that caused necrosis. But with diabetes, there's never intravitreal fibrosis. Never happened. It's always at the outer surface of this posterior vitreous cortex. So when it's pulling on the retina, as graphically depicted in this illustration, you must truncate, as I call it, this conical shape. If the posterior aspect of the cone is very broad, that indicates broad areas of traction. If it's a tight conical element, it's often inserted on the optic nerve head and sometimes mistaken for total retinal detachment on ultrasound. So again, if it's very a tight, a small apex in the back, usually it's on the optic nerve, occasionally on the supratemporal and infratemporal vessels. So even in an opaque media eye, you can look at the shape of this posterior vitreous cortex, even if it's opaque, and kind of judge what's going on, which will help correlate with your imaging, your ultrasonic imaging information. Pulling on this to make a PVD is the biggest mistake that's commonly made in vitrectomy. Simply do not do this. You don't just make breaks at the posterior edge of, the outer edge of the traction attachment posteriorly. You also make breaks periphery. Why would that be? Well, vitreous is permanently adherent to the retina at the vitreous base. Permanently adherent, and you'll never ever peel vitreous off the pre-equatorial retina. It's permanently adherent. And the tensile strength of peripheral retina, as Makamer showed, is 1/100th that of the central retina. So by pulling on this, not only do you risk posterior breaks, but you risk peripheral breaks that may be out of your view in a patient with hemorrhage in the periphery. And so it's this notion that the algorithm is first do a core, there is no core, then second make a PVD, making a PVD is dangerous. Please don't do that. Take the cutter to the vitreous. So I've heard people use this ridiculous term, flow efficiency. Oh, 23 gauge has more flow efficiency than 25 or 27. There is no such term as flow efficiency. There's flow or efficiency. Efficiency is the amount of vitreous removed per infusate volume, per BSS volume. That is totally a function of technique, has nothing to do with duty cycle or dual port cutters or cutting rates or the diameter of the cutter, with all respect to the hydropoceal law that says that the fluidic resistance is proportional to the fourth power of the diameter. So let me repeat. The idea that, oh, well, this is a dense hemorrhage, we want a 23 gauge cutter because it has more flow efficiency. Nonsense, complete nonsense. Take the port to the vitreous. Don't draw the vitreous to the port. This is exactly the opposite of what's done in phaco. In phaco, the whole point with cortical cleaving hydrodissection, hydrodelineation, cracking, chopping, pre-chopping, and rotation, divide and conquer, all of these methods are very appropriate to protect capsule, to mobilize lens material. I've watched McCool and Sioni, personally two of the best cataract surgeons on the planet. The phaco tip hardly moves. It stays in the middle of the capsular bag and the lens material is mobilized to it. Perfect for cataract surgery, exactly the opposite of what you want to do in retina. So when I've heard people say, well, I like 23 gauge, there's greater flow efficiency, you're not doing it right. Take the port to the vitreous. 25 and 27 work just fine in traction attachment and vitreous hemorrhage cases and are in fact advantageous. Why? For one, as there's dense epiretinal membranes in the port and it has what I call SED, sudden elastic deformation, virtually analogous to an occlusion break in phaco. That surge that happens is limited when you have a small diameter, just as it is in phaco. High cutting rates also reduce this high frequency pulsatile vitreoretinal traction. So if it's a long chain of little pulses of fluid that go through the port, little sips, if you will, instead of big gulps. You simply don't jerk on the retina. You don't have pulsatile vitreoretinal traction of as great an amplitude. So high cutting rates are always better. So when I hear people say, oh, well, no, you should use 3D or dual linear, use low cutting rates during the core vitrectomy, completely wrong. You use the high cutting rate for all tasks in all cases, absolutely essential. I reported with Stanley Chang and Brooks McEwen some years ago using laser for hemostasis. It's better. How did I discover that? By making mistakes. I did many, many diabetic traction attachments. I used diathermy to suppress bleeding, and as many of us still do, many people still do. And then I would see the 3-month post-op, and the retina would look great. 6-month, 1 year post-op, large atrophic holes, so-called ischemic, so-called atrophic holes, round holes in the posterior pole. And I looked back at the 3-week picture, it wasn't there. So it wasn't iatrogenic in the sense of mechanically induced at the time of surgery. And I'm like, what is going on? I finally reviewed all the op notes. In every instance, it's where I treated with diathermy. So there's, if you will, not immediately apparent damage to the retina that results in necrosis down the road if you use diathermy. Diathermy is not smart. It cooks everything within a spherical pattern at the tip with its radio frequency energy. Whereas, if you use a 532 nanometer, in other words, green laser, as almost all of us use, you should never use a near infrared, a red laser. Always use a green laser, 532 nanometers, and that's ideal for absorption in the blood column. So if you treat vessels, even bleeding overlying the arcades, even bleeding just above the disc, you can do that with very carefully and avoid damaging the major arterioles, avoid damaging the disc. So I strongly prefer laser for hemostasis. Those who believe laser can only be absorbed in the pigment epithelium just don't get it. It absorbs perfectly well in the hemoglobin blood column. What better to absorb green light than red blood? So if you will, direct the laser energy toward a vessel, then the vessel, you have to use, don't use these 20, 30 millisecond pulses we use in the office. You got to use continuous laser, so otherwise you'll just get a spasm and it'll open right back up. Use this for hemostasis, far better than diathermy. A major point that I've been emphasizing for years now, but it's shocking to me that almost everybody still uses diathermy. Let's skip over that. So what about using the cutter for everything, so-called cutter delamination? There are two specific types, and I coined these names. One is fold-back delamination. That, while safe, and people normally show it in their videos, see how easy you can use the cutter. They'll say, see, I can do all my diabetics with the cutter. Yeah, you can do easy cases that way, but not hard cases, not tabletops. And so fold-back delamination works when the membrane is flexible and thin, and the advantage of it is there's membrane between the cutter port and the retina. What about conformal delamination? That's what you must do if the membrane's rigid and won't fold back. In this case, you must apply the port, not direct the port toward you, not upwards, but feed it in like you're eating a sandwich. You don't suck the membrane into the port, and you don't push it into the port. You slowly advance it like you would pushing wood into a table saw or a lawnmower over the grass. So it's feeding it in at the proper feed rate, and precise positioning of the port relative to the membrane is important. Why did I coin the term conformal? To indicate you must rotate the cutter around its long axis to make sure there's a bit of an up tilt so the port is not directed toward retina. Very important. So this is conformal cutter delamination. You're on the edge of the membrane. And I want to thank Byron Wood in our office for doing all these wonderful graphics that are in my book. And so here you're not protected. The membrane is not between the port and the retina. So this is what you must do if it's rigid. On the other hand, if it's flexible like this, it will fold back into the port, and now you got membrane between you. And so this is the best way to do it if you can do it. So you position just behind the leading cut edge so it will fold up into the port as depicted here. When do you need scissors? Anytime the epiretinal membrane is adherent to the macula, broad zones of adherence, customarily called tabletop traction attachments, very dense membrane with marked adherence to thin atrophic retina, particularly the mid-peripheral retina, particularly retina that's very ischemic, white vessels, retina that's been PRP'd with intensely before, or chronic TRDs where there's more atrophy. So thin retina with densely adherent membrane. If you try to delaminate, if you try to do that with a cutter, you're likely to make retinal breaks. So sometimes you just segment that if it's not elevating the macula, but in other instances, you will delaminate. What scissors should you use? When I first invented segmentation, I used so-called vertical scissors, as depicted on the left side of this slide. When I invented delamination, I used so-called horizontal scissors, actually 135 degrees. But once Grishaber was able to make these wonderful curved scissors, I use curved scissors for both segmentation and delamination. Numerous people don't get that. They say, oh, no, for segmentation, you got to use vertical scissors, and for delamination, you got to use the horizontal scissors. Mistake. Curved scissors are better. Why? What's the shape of the posterior wall of the eye? Curved toward you. Well, curved scissors are less likely to impale the scissors port in the retina. But this slide depicts another reason. Blade width is greater than blade thickness. The distance between membrane and retina is basically a potential space. So there's this big gap that you can introduce something in. So if you got something thinner to introduce in the gap, namely the thickness of a curved scissor blade, it's better. And there's another reason. In most cases, you're doing access segmentation followed by delamination. So you wouldn't want to use two pairs of scissors. One is more expensive, and you got to do tool exchange. So if you're doing access segmentation, you simply rotate your hand slightly along the axis of the tool, and now you've converted a segmentation device into a delamination device. Very useful. So this lists, again, the reasons you should use curved scissors rather than vertical or horizontal. If you do 27 gauge surgery, curved scissors won't fit through it. The vertical scissors from Alcon Grishaber actually work quite well, as depicted here. So I again emphasize the use of curved scissors for both delamination and segmentation if you're a 25 gauge surgeon, or use of these straight scissors depicted here if you're a 27 gauge surgeon. What's the role of segmentation today? The primary role is access to the delamination plane. So I call it access segmentation. Typically, you should proceed in an inside-out direction from the optic nerve outwards along the temporal arcades. Develop the plane so you can find it. Don't use picks and peeling to do that. Use scissors to do that. Once you eliminate the adherence of this block of epiretinal membrane to the optic nerve, you can proceed outward as depicted here. But again, if there's dense membrane overlying thin atrophic retina in these post-PRP ischemic chronic scenarios, you can use access segmentation, simply use segmentation and don't follow with delamination. If you've had excessive bleeding scenarios, glial recurrence, reproliferation in the other eye, sometimes a few cuts with segmentation is enough and leave much of the epiretinal membrane behind. This depicts access segmentation. We're not finishing at this point. This just allows us to rotate the scissors and proceed with delamination. Should you put the scissors in wide open and close them? No, you'll tear these little attachment points, tear the retina. The retina is 1/100th the tensile strength of the membrane on average. If you put the scissors in closed and open them, sort of blunt dissection techniques used in general surgery, again, you tear at these attachment points. So you should introduce the scissors almost closed and cut right at the tips. Remember, scissors cut at a point, not on a line, and that point moves outward as the scissors blades close. So move it forward, almost close it, and cut right near the tip. Don't do this spreading phenomenon which causes retinal breaks as depicted here. Use this technique of having it almost closed and moving the scissors from side to side, searching for these little attachment points. You don't need to use bimanual surgery and tug on this membrane, as many people do. It creates many iatrogenic retinal breaks. I'm not a big fan of bimanual surgery. Very few people do it well. What direction should the delamination proceed? Inside out. The central retina is thicker, more redundant. The membrane's thicker, more visible at that point, and you can devascularize the whole plate of membrane by detaching vessels from the disc. So many reasons to move inside out in most cases, typically on the temporal side of the optic nerve. This depicts inside out delamination. There's been a little access segmentation cut preceding sort of the 12 o'clock in this picture, and now we're taking these curved scissors and delaminating outwards to eliminate these little attachment points between membrane and retina. Once you've done that, you can then remove the posterior vitreous cortex. Notice that there was not a PVD created in this case. The delamination preceded removal of the posterior vitreous cortex, which is always in continuum with this plate of epiretinal membrane. So this idea of delamination before vitreous cortex truncation is an important one. So when do you do that? If there's no PVD or minimal PVD, don't just pull until you make one and cause retinal breaks. Simply start at the optic nerve head and delaminate outwards, and then you'll see that this the outer edge of dense epiretinal membrane is always contiguous with the posterior vitreous cortex. So it'll be very easy to see this, and this is a far better way to proceed. This whole notion of en bloc is annoying to me, quite honestly. How did this come about? I reported delamination first. I reported this inside-out orientation. Others renamed it en bloc, published it, and said the point is to go outside in and use the vitreous to pull on the membrane and lift it. That is a guaranteed way to make peripheral retinal breaks. That is absolutely inappropriate. But even the term en bloc, what does it mean? In one piece. Highly appropriate for cancer surgery, absolutely inappropriate for vitreoretinal traction attachment repair. Why? It makes no sense to remove it in one piece. Well, they say, that's not what I meant. Well, don't use that name then. What should you do? Delaminate inside out and segment it into some pieces. Why? You can't look at everything at the same time. You're focused on the scissors, and when you're delaminating, say on the supratemporal vessels, you're going to have a little push out force in the scissors, and you can inadvertently be applying traction to the infratemporal vessels or to the nasal retina or to the periphery. And so if you try to move it in one big piece, which is what an en bloc should imply from a semantic perspective, that's a mistake. Simply don't do that. So delaminate inside out, but cut it into some pieces. Far safer, far better. What about bimanual surgery? Sounds like a good idea, but we always use two hands. So let's talk about what instruments will be, and if you believe yourself to be a bimanual surgeon. I always use two hands, but I don't call myself a bimanual surgeon. One, if you have scissors in one hand and forceps in the other, and you're dexterous, and you want to hold the membrane still so you can carefully delaminate, I get it. You got to have a chandelier. That's a good idea. But if you have a pick in one hand and a cutter in the other hand, which some people call bimanual surgery, that implies you're a peeler. And if you peel in diabetic traction attachments, you make retinal breaks. If you have a forceps in one hand and a cutter in the other hand, it's okay. But again, scissors in one hand for the difficult cases and forceps in the other are the best combination, the safest, so that you don't make inadvertent breaks by inadvertently lifting to expose the plane. You don't need to see up underneath the membrane. It will elastically scroll up on its own as you cut. Chandelier illumination frees up the endoilluminator, but it doesn't provide as good illumination as an endoilluminator because it's not focal and it's not retro and it's not specular, it's broad. So what are the disadvantages? Shadowing and glare with fluid air exchange. Of course, you got to make a fourth wound. If you're going to do forceps plus scissors bimanual surgery for certain difficult cases, then you must use the chandelier. The Alcon one is advantageous because it has a malleable shaft that positions it for you, and you can use a trocar candle to place it so that you take the same quality of wound construction there to prevent vitreous wick and leakage as you do for your other three wounds. I don't use peeling at all in diabetic traction attachments. I don't know why people start with this exercise. It's like starting to do an intercap and converting to phaco. Makes no sense to me, but I don't get it. Now, if you have macular distortion, once epiretinal membrane along the arcades has been delaminated, okay, ILM peeling is just fine, and that should be done with forceps, not with picks, tissue manipulators, and spatulas. So how should we do hemostasis? As I told you, the laser seems to be a better way to do it because it limits damage to the vessels. And that's the end of the presentation. There's one point that I should have put in here that occurred to me operating yesterday with our fellow. When you do a diabetic vitreous hemorrhage, there's a tendency, of course, to pay most attention to NVD, disc, neovascularization of the disc, and as well as posteriorly. But in fact, you should pay attention to the periphery as well. Why? There's often little tufts of neovascularization, so-called NVE, even at the equator, that'll be adherent to the posterior vitreous cortex. If you don't carefully remove traction to those, post-op hemorrhages can be caused by this so-called skirt of remaining peripheral vitreous tugging on these sites when the patient has a saccade, typically when sleeping and the blood pressure is higher, and they'll get a bleed. So I think that's an important thing to think about. Glad to answer any questions. Let me look here and see if there's some that are up. Okay, so I was asked about what's the technique for complete hyaloid removal in diabetic retinopathy surgery. I've actually just described it, but the point isn't complete removal. So for example, if you've got a traction attachment, peripheral vitreous shaving is completely inappropriate. It's a ritualistic behavior people use, absolutely necessary in giant breaks and PBR and regmatage detachment, but in posterior pole disease, macular surgery, and moderate-sized traction attachments, peripheral vitreous shaving has no role. Don't do it. Don't make aggressive PVDs. I've said this over and over and over again. If there's vitreomacular traction or a traction attachment, truncate and then resect outwards toward the skirt, not emphasizing peripheral vitreous shaving, which, as I said, is overdone. I think this is a very, very important thing. So recurrence is about tissue damage. It's not about leaving tissue behind. With the exception of the point I made, if you leave epicenters and they bleed from their cut edges, then a fibrin bridge will occur and gliosis can occur across that fibrin bridge. That's an important thing. With respect to bleeding, how do I control it? If I don't do pre-coagulation, so I don't take the diathermy and cook everything that's red like so many people do, because it causes retinal necrosis and increases the likelihood of retinal breaks, even intraoperatively. So what do? I delaminate. If I encounter a bleeder, I immediately raise the intraocular pressure with the foot pedal to stop the bleed. I then take the laser and introduce it, and the valve cannulas are nice because the pressure doesn't drop when you change tools, and then I'll laser that area, and it works quite well. Let me zoom down and see if there's some other questions here useful. I was asked a question about complete vitrectomy. I think I've already addressed that. Let's address something else. There was a question about reoperation. You do a diabetic vitrectomy, you do everything you can to achieve hemostasis, you get a good result surgically in the first post-op day or a day or two or three later, they bleed. What do you do then? What you should do then is to first do an ultrasound to make sure there's no detachment. If there's no detachment and there's no iris neovascularization, wait. How do I handle this? I talk to the patient, and I say, first you got to know what the vision is in the other eye. If the vision's good in the other eye, waiting's appropriate. If the vision's bad in the other eye and the patient feels up to it, you might want to reoperate relatively soon. If the blood is very dense, you're much more likely to have to reoperate than if it's quite liquid and not so dense. So I tell the patient, this is a common occurrence. We've dissected scar tissue that has blood vessels in it. You can't coagulate everything safely. So don't worry, the blood's not going to damage your eye. Now, if it's driving you crazy, we can remove it in a couple, 2, 3, 4 weeks. But on the other hand, if it's not driving you crazy and you got good vision in the other eye, we'll monitor you with ultrasound, and we can wait a month or 2 or 3. So I'll tell the patient, why don't you pick a time you're comfortable with? I know it's not fun to be reoperated, and I know it's not fun to have blood blocking your vision. So why don't you pick a time, maybe about a month or so? What do you think? And they'll say, yeah, I'll come back and see you in a month. It seems to be getting a little better every day. So that's the kind of discussion you'll have typically at the 3-week visit. What are my laser parameters? Always use continuous laser for retinal breaks and for hemostasis. I actually... when we do PRP, I don't like the repeat mode because there's a tendency to walk it through the macula if you're not paying attention. And I don't want to treat over an area of prior treatment with laser. So there's a tendency to just make these tidy little rows and laser on top of prior laser marks if you do repeat mode. So I push the pedal individually for each spot. Let's see here. Any more questions? So this is asking about laser versus anti-VEGF agents. The diabetic retinopathy, DRCR network, the diabetic retinopathy clinical research network, drcr.net, has made this very clear. It's absolutely clear that anti-VEGF compounds are more effective than laser or steroids. I don't use, so if the patient, if you believe truly in your heart this is a one-time visit to your office and they've got neovascularization or they got microaneurysms, leakage, or macular edema, and treat them with anti-VEGF compounds and laser. I used to tell the residents, knock it down with Avastin, keep it down with laser. But if you think the patient's going to be able to come back in a month and again, then use anti-VEGF compounds in lieu of laser. Laser works. But when I hear these people touting ultra-wide field angiography, which is ridiculous, to find the peripheral ischemic areas to do targeted photocoagulation, it is utter nonsense. It's been disproven as a thesis But clinically, here's what happens. In my office, I've been doing this a long time, numerous patients with very, very dense PRPs, 3 or 4 sessions of PRP, almost a wall-to-wall PRP. They come in our office, it looks stable on indirect ophthalmoscopy or maybe the 90 diopter lens, and you get an OCT and there's macular edema. Well, where were you going to laser? If you take that same patient and treat him with anti-VEGF compounds and Eylea is better than Lucentis, which is better than Avastin, it's diabetic macular edema goes away. So what role does this ultra-wide field peripheral angiography finding targeted ischemia have? None, in my opinion. Massively overdone as a notion. The question is asked, should I leave air in the end of the eye or leave gas? We always think that the idea that air would retard bleeding, I'm not so sure. There's a paper, I don't have the reference in my head, but that concluded that air did not produce less. I'm also asked about silicone oil. I try not to use silicone oil in these cases for the reasons I've already illustrated. If you must use it, I often don't do any retinopexy, and I use it for what I call regnematogenous confinement and retinopexy avoidance. That's a major advantage, actually, of oil, that you don't need to do laser. So I see these people put in oil, and then they laser all over everywhere, and they've created a tremendous amount of reproliferation just from the laser-induced damage. So I largely use laser in very difficult cases that I'm likely, use oil in very difficult cases I'm likely not ever to be able to remove the oil. And then I'm also asked here about double staining. I don't use that terminology, but let's address staining. In the diabetic traction attachment case, I rarely stain. If there's obviously sort of corrugation or folds to the macula, then I use brilliant blue to stain for that. Kenalog or triamcinolone or triasis is not a stain. It's a particulate marker. I don't find it necessary, but I use focal illumination with an illuminator, not a chandelier. If you use a chandelier, you can't see the vitreous. If you use Ingenuity, you can see clear vitreous better. But if you use the light reflected off the vitreous cutter in a focal illumination and retro illumination manner, focal like a slit lamp beam and retro by bouncing it off the vitreous cutter, you can see the vitreous without having to introduce this additional variable and cost and risk factor of putting triamcinolone in the eye. So I don't do that. I think that's all the time we have, so I want to thank everybody for listening and hope this was useful to everyone. And please participate in Orbis going forward. It's a wonderful organization. I want to thank Orbis for making this possible. Thank you.
Thank you, Dr. Charles.
You're welcome. Hi, this is Steve Charles in Memphis, Tennessee. I've just flown back from England, from the Royal College, and I'll do the best I can to be articulate. I appreciate 169 people so far have signed up for this seminar. Hopefully some more will join. I'm going to talk this evening on vitreomacular surgery update. Obviously that encompasses a variety of diseases, and we'll go through them one by one. One thing that I want to start out with is that if you look at the top picture, you'll see a typical epiretinal membrane. I usually show these in the opposite grayscale video with white tissue, if you will, on a black background. It shows better. But in this case, I've inverted the video to make a case that numerous patients are said to have edema based on central foveal thickness measurements, based on volume measurements, or sort of the topography type map of thickness. This is simply not edema. It's structural, and I call it foveal inversion, and it goes away, but it takes 18 months when you peel the membrane. But I've heard surgeons look at an image like this post-op and say, oh, they need intravitreal steroids. It's edema. It's not edema. There's no cystic fluid spaces, and it will go away with time. Or I've had them misinterpret patients as saying, oh, if you have cataract surgery and you have an epivacuum membrane, you're more likely to get macular edema. No, you're not any more likely to get inflammatory or Irvine gas macular edema than the next patient. It's just thickness misinterpreted as edema. So now let's move on to the impact of that. One is intravitreal steroids not only will not help, but if there's up to a 30 to 40% chance of steroid glaucoma if you use triamcinolone, and virtually 100% of cataracts. So I would strongly encourage you to stay away from centrofoveal thickness except in clinical trial context, or these topographic maps or color coding, and look at the black and white images both preoperatively and postoperatively. I've also had another problem with respect to surgical indications, and that is patients like the image at the top have been said to have retinal disorganization, not true, or intraretinal fibrosis, not true, and therefore inoperable, not true. The bottom picture is the same patient after ILM peeling. But as I'll say many times, if you don't ILM peel in this situation, you will not get the level of structural improvement. The way I like to say it, if any tissue, vitreous, membrane, or even some other things like hypotony distort the macula, if you don't peel off the ILM, it won't go back to its normal shape. You must peel ILM to make the retina compliant instead of elastic and taut as it is when the membranes of ILM's in place. 27 or 25 gauge transconjunctival sutureless is the standard of care. There's absolutely no reason to use 23 gauge. They have a higher incidence of wound leaks, etc. And I've always used the forceps. So here I want to emphasize a point that I'll emphasize over and over again. I am opposed to scrapers and picks and blades of any type. The notion that you must make an edge or look for the outside edge is simply incorrect. I've emphasized forceps membrane peeling now for 40 years. For 40 decades, I invented end grasping forceps membrane peeling, but it needs to be done inside out, not starting with a scraper or a pick or a diamond dusted scraper or any sharp needle to make the edge, but simply by pinch peeling. But that only works if the forceps grab right at the leading edge. More about that in an upcoming slide. You can see that the forceps from Alcon and others have attempted to imitate this. I'm not here to sell Alcon products. Grasp right at the leading edge of the forceps, not along some plate. So I don't approve of the so-called asymmetric forceps or more of the alligator configuration forceps. I only approve of these that are smooth and grasp right at the leading edge. And this makes a major difference. It's the enabling technology. At some point, I began calling this pinch peeling. This is another way to think about it. So in-grasping forceps membrane peeling is the standard, whether it's an epimacular membrane, a macular hole for ILM peeling, vitreomacular schisis, vitreomacular traction syndrome, or peeling for other indications we'll talk about. So what are the benefits? One, you don't have a sharp instrument in the eye. Patients move on the operating table. These are done at or local. And two, you don't have the issue of trying to find the diaphanous thinner outer margin of these so-called glassy or cellophane epiretinal membranes. If they're thick, you can kind of see the outside edge. But if they're thin and have specular reflection, kind of shiny, it's very difficult to see the outside edge. So you don't have to put a pointed object or something that damages the nerve fiber layer or with a lot of downforce on the retina, like some of the scrapers do, or all of them do actually. So again, we want to start where? We want to start at the epicenter. What is that? How do I know what's an epicenter? If the stria in the retina point to the epicenter, that's one way to tell. It's somewhat more matte finish rather than transparent, and so it's at the apparent center. Staining certainly helps, but I don't use the term inverse staining, but some do, to point out that when you stain with brilliant blue, which strains the internal limiting membrane and is very safe, unlike ICG, which I do not use, although many are forced to use it because of regulatory reasons. When you stain with those, if there's membrane in place, then there's no staining where the membrane's still there, and that's what some people call inverse staining. And that's another useful technique. I never, ever use triamcinolone to mark the epiretinal membranes. It is a mistake in my view. It is no more specific to the ILM than it is to seeing if there's dust on your countertop at the hotel to see if the maid had dusted it off. So it is certainly useful to visualize vitreous, but now when you use Ingenuity, you see vitreous so well anyhow, I really find no need for triamcinolone particulate marking of vitreous, and I've never seen any need to use triamcinolone for the ILM. So what are my indications for ILM peeling? all lamellar and full thickness holes. Those who, for a variety of reasons, somehow feel that ILM peeling is dangerous or traumatic, say, well, it's only a partial thickness hole. I don't need to ILM peel. I disagree with that. If you want to return a partial thickness hole to a proper a proper anatomy, foveal anatomy, restore normal anatomic configuration, it's not going to happen if you don't peel the ILM. So what I've seen over and over again, people say, oh, it's a partial thickness hole, it's symptomatic, therefore I'm going to do a vitrectomy and peel off the PVD. Many of these patients already have a PVD with the lamellar macular holes, but peeling vitreous away from the optic nerve head allows gas bubble access to the retinal surface, but it has nothing to do with fixing the macular hole per se. The gas bubble does for reasons we'll discuss. So I use ILM peeling in every epimacular membrane case, every vitreomacroschisis case, all vitreomacular traction syndrome, whether they're diabetic or not, many diabetic traction attachments, and frankly, more and more PVR cases. I learned from a Spanish author that hypotony maculopathy can be treated. And I haven't had a large number of cases from the glaucoma specialist, but I have seen some, and they actually do quite well. If you do internal drainage of subretinal fluid and internal fluid air exchange improperly when fixing rhegmatogenous retinal detachments, you can create a macular fold. This usually occurs because you do fluid air exchange before drainage and you push retina posteriorly. And those folds, I do not find any need, if someone creates a fold, to redetach the retina. If you simply peel ILM over time, the retina will restore to near normal configuration. So what are the advantages of ILM peeling in the context of epimacular membrane surgery? One is it reduces the recurrence rates, as Anselm Kampnick from Germany pointed out. This was my wake-up call when Professor Kampnick brought this to our attention. Why is that the case? Because the basement membrane for what we at the time thought were modified astrocytes that cause glial recurrences, we now known to be Mueller cell, are the progenitor cells for gliosis, reactive gliosis, in whether it's PVR or diabetic recurrences on the retinal surface or in epimacular membrane recurrences. It's Mueller cell reactive gliosis that's occurring. At any rate, if you eliminate the basement membrane, then you eliminate this problem for the most part. We have an incredibly low recurrence rate. Probably, if you really have a good view and the patient holds still on the table, it's essentially zero once you ILM peel. Secondly, if you don't ILM peel, the stria will not go away. The retina is sort of fixed in that position by the ILM, in that folded position. So I had the experience over many years before ILM peeling was introduced for this application of peeling off a membrane, documenting it on video, and then post-operatively the folds are still there. And the referring doctor said, gee, didn't you peel the membrane? So I've learned my lesson. When the stria are completely gone, there's still room for further visual improvement lasting out to at least 18 months after surgery. Why is that? Because rods and cones are shaped like rods and cones, and when light is on axis, they are 30 dBs more sensitive than they are when it's off axis. This is called the Stiles-Crawford effect. There's not a clinical machine for testing that, but Jay Enoch at Ohio State did a lot of work in this area, and this is clearly the case. And so, fortunately, photoreceptors adaptively realign at the nodal point, but it takes many, many months, and long after the retina appears normal on OCT. And so doctors that don't check the patient's vision 18 months or 2 years out have an incorrect impression about the level of visual improvement. I'm absolutely distraught if the patient isn't 20, 30 or better after epimacular membrane surgery. Yet there's papers in the literature that believe that 2080s or 2070s an average outcome. That's simply because ILM peeling was not properly done, or my fear is that there are many, many cases of ICG toxicity out there. The third reason to peel off the ILM is that you guarantee removal of everything anterior to it. Clearly, if the ILM's gone, all epiretinal membrane and all residual vitreous cortex is gone. As we've learned over the years, seeing a Weiss ring in no way indicates that there's a problem with seeing a Weiss ring in no way indicates that a PVD has occurred in the sense of complete removal of vitreous from the retinal surface. vitreous remains on the retinal surface. I remind you, it's the vitreous cortex, not the vitreous face, so there are multiple layers. This demonstrates the intimate relationship of the ILM and the Mueller cells. The Mueller cells, of course, are columnar. When you successfully peel ILM, on occasion, you see what two of my ex-fellows, Eric Sigler and John Randolph, reported, which is what they call interretinal layer cystic change. This is not edema, and it doesn't respond to steroids. It may respond somewhat to anti-VEGF compounds we're learning lately, but again, it's not edema. Some people call it retinal dimples, which I think is a ridiculous term. Others call it dissociated optic nerve fiber layer, which is not the problem either. The problem is a avulsion of the Mueller cell foot plates, and that's, in my view, why the term interretinal layer cystic change is more appropriate. How can you identify this on OCT? The little cystic spaces are columnar, following the shape of Mueller cells. And so there are certainly people who are overly aggressive with ILM peeling, using scrapers and so on and so forth, that actually do dissociate the nerve fiber layer. But if you use proper visualization and proper forceps techniques and don't use scrapers, you will not routinely dissociate the optic nerve fiber, yet you will have this interretinal layer cystic change. It can actually be seen preoperatively when there's extremely aggressive traction as well. ILM staining is absolutely essential. I am stunned with how much I missed before ILM peeling was introduced. I use this in every single, I see staining in every single case of macular surgery, that list that I illustrated earlier. Fortunately, it's approved in Europe and available in many other countries. You must be very careful if a compounding pharmacy makes this, that it's made properly. We know there was some off-brand PFO in Spain that ruined a number of eyes, and this certainly could happen from Brilliant Blue as well, although I'm not aware of much of this happening. Just a few isolated cases from bad compounding pharmacies. In the United States, it's not FDA approved, so as I said, it has to be prepared by a compounding pharmacy. But fortunately, it's approved in Europe as Brilliant Peel and available in Asia and many countries as well. What are the advantages of Brilliant Blue over ICG? It's dissolved in BSS, not water. It's not fluorescent, so there's less risk of phototoxicity. It has a stable pH and osmolarity. There's no need to infuse it under air. And one of the big advantages, in addition to not being toxic, is that you can repeat it. So it's very common for me to inject Brilliant Blue 2, 3, 4, 5 times in a case. I keep it in the refrigerator until immediately before use, so it sinks from convention. So you don't have to inject aggressively to get it on the retinal surface. And I use the 3 cc syringe, which instead of a 1 cc syringe, this decreases the throw of my finger on the plunger, but more importantly, in some ways, it slows down the jet that comes out the other and prevents you from making a little retinal break with hydraulic pressure and causing Brilliant Blue to go underneath the retina. How should you view the macula? I am absolutely opposed to the use of the Recite or the Biome for macular surgery. A plano contact lens gets rid of all corneal asphericity, and I think it's absolutely the appropriate way to view the macula. It does not take another physician or surgeon to hold the contact lens. Technicians do it very, very well. Just tell them to keep it parallel to the floor and don't press down, and be nice to them. Don't yell at them. And you'll find that this non-contact viewing is far better for macular surgery, in my view. I use Ingenuity for all cases. I know many don't have access to it yet. This increases the depth of field by 2.6x and is another tremendous advantage in doing macular surgery. The motion should be, first of all, this shows how you're grasping in the epicenter of the membrane, not at some manufactured edge or at the outer edge, outer margin. So again, epicenter, in the middle, where the stria point, and you grasp right, you pinch peel right just at the level of the membrane. If you lift and there's the slightest distortion of the retina, let go and move to another location. With 27 and 25 gauge forceps, you can see them bend and you interpret that as tactile feedback. There's also some tactile feedback to your fingers, and you can tell the ILM because it feels elastic, unlike retina. And the motion should be circular, not unlike capsular rhexis, and you can steer the direction that you turn. And this motion is the same whether you're peeling an epiretinal membrane or peeling ILM. The technique is the same. Sometimes the membrane is very adherent and you'll peel both in one layer. I make no attempt to try to be in one layer or be in two layers. I just grasp the surface at the epicenter and peel, and then I restain. If the ILM went with it, the stain will be on the bottom of the epiretinal membrane in some areas, but when you restain, you'll see that the ILM is gone. It's commonly spoken on the podium, meeting after meeting, and it's published in numerous places, that vitrectomy causes cataract. It's simply false. It's been false forever, but it's stated by surgeon after surgeon who wants to justify scleral buckling. When I've traded off scleral buckling for vitrectomy to repair all retinal detachments. But what does occur is inevitable progression of nuclear sclerotic cataract. If there's no pre-op nuclear sclerosis, you don't get a cataract from vitrectomy. I've got literally 1,000 patients, estimated of course, that have had vitrectomy surgery 10, 15, 20 years ago, maybe more, and they don't have a cataract. Why? They were 20, 30, maybe 40, and had no cataract when we started. But if there's any nuclear sclerosis present, it will progress. Why? It's been shown by Nancy Holtkamp, who actually measured it, and Einar Steffensen, who measured oxygen levels in patients, as well as Stanley Chang, who postulated that the oxygen tension in the vitreous cavity goes up by 12 millimeters, the partial pressure of oxygen goes up by 12 millimeters of mercury permanently. It has nothing to do with the infusion fluid. Infusion fluid, if you use off-brand infusion fluid and you're unwise enough to put dextrose in it or to put bicarbonate in it instead of using BSS or BSS plus, or if you put epinephrine in it, you can cause a posterior subcapsular cataract, which is just simply chemical toxicity. I never add anything to the BSS plus. I think it's a big mistake, and I never see posterior subcapsular cataract during vitrectomy. I haven't for 35 years since BSS plus was introduced. Numerous surgeons use this justification, or the justification of only having to see the patient once, to do phaco-vit in all their cases. If you're a really good phaco surgeon, and numerous vitreoretinal surgeons in my view are not, yes, you can take the cataract out and put an implant in and go on and do retinal surgery. But it's not infrequent to have the pupil come down, or to have a little haze in the cornea, or a slight bit of stria, and now your visualization is compromised. But even if you're perfect in your phaco and there's no compromise to your visualization, you have another issue, and that is it's very hard to get the right refractive outcomes when you're doing combined procedures. Patients today prefer to be emmetropic after surgery, or to get their desired monovision or whatever it is. And if you're using multifocal lenses or torics, which many patients want, I'm opposed to multifocal lenses in any patient with macular disease, but torics are a wonderful lens to use. And I know numerous vitreoretinal surgeons that routinely do phaco-vit when they shouldn't, and they never use a toric. So now they've elected to not have a wonderful and safe treatment for the patient's astigmatism, which I think is a mistake. So I strongly prefer separate procedures. So how do I decide? If the patient has a posterior subcap or has 3 or 4 plus nuclear sclerosis, phaco surgeon does it first, we wait a month, and then I do the macular surgery. If the patient has 1, maybe 2 plus nuclear sclerosis, I do the vitrectomy first, and then I send the patient for the cataract surgeon for cataract surgery. If they're going to do the surgery first, you must caution the cataract surgeon to measure the axial length optically with low coherence interferometry from the pigment epithelium. So that means the Hochstreit Lenstar 9000 or the Humphrey IOL Master. You have to use optical means to measure axial length. If there's substantial cataract, of course, you can't do that, and that's another issue. So let's shift gears and talk about macular holes. Now, we talked about membranes. What causes macular holes? And the answer is nobody knows. Yes, Don Gass put a theoretical explanation, which everybody feels compelled to describe in every single talk on macular holes, but it hasn't been proven. For example, if 70% of the population get a PVD, what's different about those patients that go on and get a macular hole? Why is there vitreous still on the retinal surface in some of the patients and other patients there's not? Why is it 2 to 3 times as common in women as it is in men? Why does it wait till average age 59? So the reality is that we have no idea precisely why patients get macular holes. We know for certain that a Weiss ring does not mean there's not vitreous on the retinal surface. The classification system is simply useless. It is erroneous. There's numerous evidence of this in the literature where people say, oh, it's a stage 1, stage 2, stage 3, stage 4. You don't know until you get to the operating room whether there's vitreous or membrane in the retinal surface or not. Numerous patients with ultrasound, it's hopeless. Even with OCT, it's hopeless to classify these patients. It is a mindless exercise that people go through. We know from Neil Kelly's and Rob Wendell's pioneering work that macular hole surgery clearly did not macular holes did not come about because there's a full thickness piece of retina missing. Well, that was widely known to be the truth. Dick Green and others published that, except it's simply not true. There's remarkable, as Mark Moonkrantz says, plasticity in return of near normal foveal anatomy, where only in a rare patient can you even see the seam where the macula comes back together. So clearly there's a plasticity role here, which is exciting. What about partial thickness macular hole surgery? I do not do that to prevent full thickness holes. One can simply not predict who's going to stay partial thickness, and we have a very effective treatment for full thickness macular holes. So I treat for one of 2 reasons. I treat partial thickness holes if they're symptomatic, if the patients have metamorphopathy, they have distortion or decreased vision, or the vision seems dimmer in that eye or defocused, which certainly can be the case with partial thickness holes, lamellar holes, or if they're structural changes visible on OCT that mean retinal damage is occurring. Schisis, subretinal fluid, or intraretinal fluid, that doesn't go away by itself, and that doesn't bode well for the long-term health of the macula. So in those cases, I operate based on the findings, not necessarily the symptoms of metamorphopsia. But again, not to prevent progression to full thickness hole. You certainly accomplish that, but once again, you don't know who to operate on and who not to operate on for that reason. But I emphasize, as I alluded to earlier, the need to do ILM peeling and use gas. Numerous people, oh, it's a partial thickness hole, we don't need to do gas. I promise you, you're not going to get satisfactory return to normal foveal anatomy without ILM peeling and without SF6. Well, let's just use air. I don't think air is as effective. Can I prove that to you statistically? No, because I'm uncomfortable randomizing. When I've seen patients that others operate with air, I believe there's a lower success rate. I have not carried that argument to the point of using C3F8, however. So I think that's important. Now, if you look at this top picture, there's a lamellar macular hole, some would call it, but there's also macular schisis. I think there was enough structural change there that this patient needed surgery. So I peel the ILM and use gas, and you can see near normalization, there's very slight foveal eversion. This will go away by the 18-month mark. How do macular holes close? In my view, during phase 1, what's the ILM peel does a couple of things. One is it makes sure there's no posterior vitreous cortex or epiretinal membrane traction, but more importantly, it increases retinal compliance, and I'll discuss that in a moment. And what does the gas do? The gas works by surface tension, not some dumb term tamponade. Tamponade comes from the French, it means to plug, not to seal. So this isn't just to keep air from going through the hole. Surface tension is an inward directed force. We'll talk more about that in a moment. But there's additional benefits of having gas in the eye. So buoyancy, Archimedes' principle, tells you where it goes but not what it does. Tamponade, again, is not a physics term. So what does it do? One, the most important factor is this lateral surface tension effect, as Vinny Raposo reported at the Club Jules Guinan in Cape Town. Very, very essential concept. But it also prevents trans-hole flow. And as I pointed out, it also prevents transretinal flow. then there is, after apposition is achieved from the gas bubble, then there's some healing, possibly from astrocytes, or more likely, now we know, from Mueller cells. I should have reworded this slide. Wolensack did an interesting experiment, took rabbits and put them in basically the retina in a strain gauge force measurement situation, and measured the elasticity of the retina, measured its biomechanical properties. He then ablated just the ILM with the excimer laser and showed that the retina was 27% longer, and there's 53.6% reduced force. So in short, you convert a tight retina to a limp, compliant retina, and that's how the gas bubble is able to cause edge-to-edge joining of the retina, of the edges of the retinal break. Let's go back here and let me talk a little bit about surface tension. Einstein's first paper when he was in the patent office was actually on surface tension. If there was a Starbucks in those days, he would have probably figured it out that way. But he noted that if particles were present on the surface of a liquid, that they clumped. And he said, "No, wait a minute. How does a particle, 100 microns away from another particle, know to clump? What force causes them to all move centrally and clump?" And he could have said, well, when kids have this little loop and they blow bubbles, they don't come out as a disc, they come out as a spherical bubble. When water droplets come out of a faucet, they don't come out as cylinders, they come out as droplets and with a little tail on them, because as they descend from under the force of gravity, the airflow pushes them into a droplet. But they would otherwise be spherical if it was in a zero gravity situation. So that force, surface tension, is what closes the hole, as again Vinnie Raposo pointed out. It pulls the retinal edges together, and ILM elasticity is what helps make that possible. We've talked about staining already, but here's an example of ICG toxicity from a major group in Nashville, Tennessee. This patient had 2400 vision from this massive ICG toxicity. The best way to see ICG toxicity is with the fundus autofluorescence using the blue laser on the Heidelberg. I've said earlier that there are those who stayed on the podium. I think Gujarat Shah is one of them, that triamcinolone is specific for the ILM. This is simply not the case. But in fact, anecdotal evidence indicates it reduces the closure rate of macular holes, and people have reported triamcinolone getting trapped in the hole, or actually entrained and trapped in the subretinal space. And again, it's not a stain, so it can be used to see the vitreous. I find Ingenuity a far better way to do it, but long before I had Ingenuity, I never ever used triamcinolone to mark the vitreous during vitreous surgery. And this is particularly important in macular hole surgery for the reasons I just stated. What's the rationale for gas? In addition to all those points I made earlier about the surface tension effect and this drying effect that I mentioned, probably the drying effect stimulates Mueller cells, again, the stated astrocytes here, to close the hole. What do you do if there's a very large hole and it won't close? Well, the technique I did for several years, which I reported, is called arcuate retinotomy. I no longer use this, and I'll tell you why in a moment. But Inesh Nikra was doing a research fellowship with Barry Cooperman in UCI in California, and called me and said, could you cut the retina somehow if there's a large hole? So I made some drawings and decided that an arcuate cut, sort of parallel to the macular hole's temporal edge, might be the best way to do it. And we reported a series of I guess over 50 cases, I don't remember the number right now, that had roughly a 2/3 or a 66% success rate. And so we'll show you what that theoretically looks like. And there's some very, very nice cases. Again, 2/3 of the cases closed, and there was quite good visual recovery. I've had edema in one case. I had a retinal detachment in another case. But for the most part, and here's an example, you can see the arcuate retinotomy temporally, but in this patient, the hole was present a long time, and although the hole closed, it's very thin, and there's, as you can see here, some foveal atrophy, so the vision was only 2200. These are the scissors we use, the same ones we use for diabetic traction attachments. But The game changed some years ago. Again, I apologize. This slide is out of date. There's now 28 cases that I've done. Tamara Mahmood, while at Duke, he's now in Michigan, reported cutting a graft from peripheral retina and placing this in a macular hole and doing direct PFO silicone oil exchange to literally put neural tissue in the hole. I'm not a fan of ILM flaps. I don't do ILM flaps. It's not neural tissue, but I'm incredibly impressed with Tamara Mahmood's technique. I've made a number of changes in the technique based on my own experience with it. There's now in IRB approved cases from 5 of us, Dr. Mahmood's series and my series, where we've now reported 49 cases with a 90% anatomic success rate. So what do I do differently now? I'll show you what this looks like. Here's a beautiful graft. This is several months out, silicone oil still in the eye. I have a 2025, a 2040, a 2080, a 2100, and a 2200, and the average hole size that I operated on with this technique was 1,018 microns. 1,018 microns. All of them failed prior surgery with ILM peeling. ILM peeling was attempted again with blue staining on every one of these patients when I went back in to do this. So I haven't done any primary surgery case until a week ago when I did a diabetic that had bilateral 1.5 disc diameter holes, almost 2 millimeter holes, and I grafted one eye, so we'll see how that works. But every other case had prior surgery. Sometimes the graft, when they're first seen post-op, is a little misshapen, as you see here, and then the shape alters with time, indicating some form of plasticity. I initially did the donor side superiorly, and because it was easier for my hand access, but now I make it just inferior to the infratemporal vessels because there's going to be a small scotoma at the donor site, and I thought it would be better if it was above fixation. It wouldn't bother the patient. Here's another graft showing you the donor site superiorly. In this patient, I did operated twice. You can see 2 donor sites, but again, the graft tissue's in place, and even though the tissue looks funny, this patient had 20/60 vision. Here's another pre-op patient that we fixed. This one, although I did a macular patch graft, I think this had primary closure, so we finally included this from the series, and I just wanted to be honest about that point. Another case, again, the donor side superiorly and the graft in place in the macula with improved vision. So the other change that I made in the series, but we'll go back one slide, is that instead of using silicone oil has very low oxygen carrying capacity and a low extraction coefficient, whereas liquid perfluorocarbon was designed as a blood substitute for Jehovah's Witnesses as well as for liquid ventilation in cases of chemical pneumonitis and acute respiratory failure. And so it's obviously, it was developed for a high oxygen carrying capacity. So I now use medium-term PFO. I've done over 1,000 patients with retinal detachments, inferior temporal and nasal giant breaks with PFO in the eye for 2 weeks. So I have a 22-year experience with leaving PFO in the eye, and I'm extremely happy with it. It's clearly non-toxic, but if you use the Alcon Perforon. So I said, let's use that technique in these patients. So now I put the graft in place under PFO. I cut the graft with the scissors after ballooning up, making a bleb with the 38 gauge cannula and bounce salt. So I balloon up a bleb. I take the diathermy, treat just the vessels. Then I cut it with scissors, and it's still in place. Then I do a PFO injection with the Med1 dual bore cannula. So now we've got the PFO in place, the graft has been cut, and I take the forceps and grab the graft and drag it a little bit at a time into the macula under the PFO with my forceps maintained right at the retinal surface, so the graft stays unfolded and properly oriented right side up, and slide this into the macula. And in 1 week, I go back and take the PFO out. So I'm very happy with this idea. What about, let's shift gears now and talk about vitreomacular traction syndrome. I don't have a slide on it, but let me say from the outset, I am 100% opposed to the use of Jetrea or acroplasmin. It was one of the questions pre-submitted to me. This is one of the other questions submitted me, what do I think about ILM flaps? And the answer is I don't do inverted ILM flaps, and I don't do Jetrea, and I've never done Jetrea once. If there's a patient that has significant vitreomacular traction and for some reason does not have, we cannot take them to the operating room. Say they had severe kyphoscoliosis or severe emphysema or congestive failure where they couldn't lay down on the operating table, or possibly an economic situation where surgery couldn't be afforded. Then pneumatic retinopexy, as reported by Clement Chang and Calvin Mine and others, and Jorge Arroyo, is actually a far better technique. It's safer, it's essentially free, and it's effective. Why not Vitrea? Vitrea, 1.5% of the time, has profound visual loss. It has a very low success rate in the first place, 25% maybe, but maybe 30. But it has 1.5% of the patients have profound visual loss, presumably from dissolving Sparcan-6, the introphotoreceptor matrix. Some patients have dislocated lenses, subluxated lenses. Other patients will get a low-level retinal detachment. The ERG is non-recordable in some. In some of these cases, these complications do not go away, and you converted a patient with 20/30, 20/40 vision preoperatively with a so-called minimally invasive technique of injecting this acroplasmin, and to a patient that can't see. And that's simply unacceptable. So I do not use Vitrea in any instance. This patient is a very important patient, and I have numerous other slides like this. This patient was seen by numerous retinal experts who opined that this is some form of cystic degeneration of the macula and nothing could be done. I said, no, this is vitreomacular schisis. I peeled the ILM. This patient went from 2200 to 2025. The patient had it both eyes, was 30 years old, was presented in major rounds in New York as well as in New Orleans, and all the experts said you can't do anything. And there are numerous other cases I have of vitreomacular schisis that have been judged to be somehow inoperable because of the cystic change. Not only does this structurally improve, more importantly, visual function improves dramatically. What I find fascinating, and I don't really have insight into this except to say it's another example of biologic complexity, is that the genesis of vitreomacular disorders has something to do with posterior vitreous separation. Clearly, we see many patients as retinal specialists that this is an acute event. Flashes, floaters, 5% incidence of retinal breaks, 6 out of 10,000 go on to get retinal detachment. Okay, so that's the classic, but there are many patients that have a slowly evolving PVD. I had it in both eyes myself and had a tiny little array of dots before the fovea. You could see them on OCT, which corresponded to what I saw visually. And over the course of close to a year, they went completely away as the vitreous finally peeled away from the retina. This is said to be due to glucose metabolism. I'm blocking on the right name for it right now. But at any rate, PVD is not always an acute, sudden event with flashes and floaters. It could be slow. But it is clearly the cause of epimacular membranes, as Roth and Foos showed many years ago. So an ILM defect is created. As I said, we used to say it was modified astrocytes that caused the problem. We now know it's reactive gliosis from Mueller cells. So glial repair makes epimacular membranes. We know that it has something to do with macular holes, but when there's still vitreous on the retinal surface, exactly why does that happen? And then we have these other patients that when the vitreous peels away, it remains adherent to the fovea, presumably from some hypocellular contraction of the vitreous collagen matrix, and they get vitreomacular traction syndrome. Why one patient gets one and one patient gets the other is anybody's guess. And again, there's no genetic factors here other than myopia, myopic vitreomacular schisis, and there's no systemic factors either. Again, very complicated. So I find this fascinating, the fact that we have slow PVDs that are related to glycolation in products is what I meant to say earlier. So another story, there's some people in Vienna, Austria, and in Detroit who seem to believe that vitreomacular traction syndrome is one of the causes of exacerbation of wet macular degeneration. I couldn't disagree more. I think this is ridiculous. And frankly, I think part of it was self-serving on those who wanted to push Vitrea. But at any rate, what's the reality? Vitreomacular traction syndrome is very common. Wet macular degeneration or neovascular AMD is also very common, and they both cause subretinal fluid and they coexist. There's absolutely no scientific evidence that they're related. They both must be treated, and they're treated separately. But sequencing matters. So I think it's important to do the best you can to dry out the macula with anti-VEGF compounds such as Eylea, Lucentis, and Avastin first, at least 2 or 3 injections, and get as much drying, as people say, as you can, and then do the vitrectomy to treat the vitreomacular traction component. If you do it first, you change the pharmacokinetics, so you shorten the duration. Szilard Keese has done some good work in this area. So we shorten it by, I guess, 2 weeks, as I recall his presentations. And so I recommend treating with anti-VEGF compounds first. But again, these are unrelated disorders that just happen to coexist because they're both common. That's my last slide. We had a tremendous number of questions that were submitted, and now if we can put those questions up, I'll be glad to do what I can to answer them. So, why don't I believe in flow-based machines in vitreoretinal surgery? The primary reason is that I've tested them in the lab blinded between the best of the peristaltic pump machines and the Venturi-based machines, and I found that there's a 250 millisecond advantage in terms of responsiveness when operating under air. Peristaltic pump machines simply don't work under air. You have to have very precise control of vacuum at low levels, which the Constellation does, but there's no proven advantage of the flow controllers. That said, the next generation of machines we're working on at Alcon will be able to have both flow control, but again, you cannot do vitrectomy under air, which is a very useful technique I've advocated for many, many years. You simply can't do that at all with peristaltic pump machine. I alluded to this in my talk, inverted flap. I have not used the inverted flap, so I'm clearly not an expert. Clearly some very excellent surgeons have advocated this and use it. However, I moved to the full thickness macular patch graft that Tamara Mahmood developed, so I don't really have any reason to use an inverted flap. I want to put neural tissue in there, not basement membrane. Next question, do I have any tips for avoiding creating a full thickness macular hole when I peel the ILM and there's a large cyst? One, proper visualization is essential. Use a flat contact lens, not the biome, or any other non-recite. Number 2, you must stain with brilliant blue, or I suppose ICG if you don't have brilliant blue. I have no experience with ICG. Thirdly, you must peel toward the macula. And don't lift. Peel tangential to the retinal surface or kind of parallel to the retinal surface and peel toward the macula. Never lift and never peel away from it. But some people actually will peel around and leave a tiny bit of ILM present right over the macular cyst. I don't have a problem with that. I have not intraoperatively created a macular hole. I've had a couple that occurred months down the line, but I haven't had one that occurred intraoperatively. And now we've changed gears dramatically, and we're talking about macular traction retinal attachment cases. I've developed scissor segmentation and delamination, and it's becoming a lost art, unfortunately. You cannot do safe, highly effective macular traction attachment surgery for diabetic traction attachment cases without having the capability of using curved scissors, delamination. The vitreous cutters with better fluidics, with the beveled cutting tip, with higher cutting rates, certainly can do more than ever before. But if you believe you can do the entire case of a diabetic traction attachment using the vitreous cutter, you're sadly wrong, and you're going to make a lot of retinal breaks. Day in, day out, people call me up and say, I'm doing a tough macular traction case. I'm planning to use membrane peeling. What? Membrane peeling? You don't use membrane peeling in traction attachments. You must shear the membrane away from the retinal surface, either with the cutter or with the scissors. And I'm planning to use oil. Oil? Why would you use oil in a diabetic traction attachment? The vast majority of the oil cases are because you didn't do the surgery right. You made retinal breaks. Don't make a PVD. Learn to use the scissors in the diabetic traction attachments, particularly the more difficult ones, the so-called tabletop attachments. So what are the tricks? avoid oil at all costs, avoid retinal breaks at all costs, and use curved scissors and the advanced cutting technologies. Now we'll go back to macular holes. How do I manage a 500 plus micron macular hole? Macular patch grafts, as I just described. So we'll go through that technique again. We make a blister, a bleb with a 38 gauge cannula with BSS, diathermize the vessels at the periphery of the bleb, cut it with scissors, leaving one little tag on the inner edge, do put PFO in place with the Med1 dual bore cannula, take the forceps, drag the graft flat against the retinal surface, position it properly, and leave the PFO in for a week. So that's how I manage big holes. What about stem cells? First of all, embryonic stem cells, I think, are never going to happen. I'm well aware that some people have published papers I don't approve, not on moral grounds, but on the fact that these patients must be immune suppressed. We don't have the capability to tissue match these patients. And availability of cells is just a huge challenge. So if we're talking about stem cells, first of all, what layer are we talking about? To date, we've only talked about the RPE, and I recommend iPSCs. Well, what iPSCs? Well, they have to be 110, 120 day process. There's over 25 tests that have to be done to make sure there's no oncogenes or helper viruses or exons or other contaminants, and to make sure that they generate an EOG, that they generate a pump mechanism. All those tests have to be done to make sure they're, as Kapil Bharti and Juan Amaral at the National Institute call, that they're authentic RPE cells. So there's some purely fraudulent work going on in Florida and other places about so-called stem cells. Mesenchymal stem cells derived from liposuction simply cannot repair retina or pigment epithelium. So that's a joke. But to repair the RPE, what about a suspension of cells? This simply does not make a functional pigment epithelium. It makes a lump of cells underneath the retina. What about iris RPE cells? They don't support the visual cycle. What about the patient's own peripheral RPE? Some believe that that there are some epigenetic factors that mean it doesn't properly support the macula. Patients that were born with that had ROP, that have an eccentric macula, as Bill Tasman reported years and years ago, lose vision later in life because there's something specific about the pigment epithelium that's under the macula as opposed to peripheral retina. So in short, not only will iris RPE cells not work, peripheral RPE cells are questionable. Cell suspensions are not useful. Embryonic stem cells, you have the problem of tissue of rejection, and therefore they're not immune. It's not an immune privilege site. So we're talking about iPSCs on a scaffold, as being the only way to do it. And although there have been some recent reports that, in my view, they were grandstanding because they removed subretinal hemorrhage and then put the stem cells in place and claimed that the stem cells made the patient see better. So we got a ways to go. So now we're asked about how to avoid making a macular hole when the VMT roof is very thin. I really addressed that earlier when I talked about cystic change, but again, it's proper visualization, flat contact, 2, staining with brilliant blue, 3, peeling toward the macula, and you can choose to leave a little cuff of ILM or right on the VM roof if you want to, although I have not done that. Then there's a broad question. It's often easy to decide when to operate in retina cases. How do you decide when not to operate? That's a great question, and it's a complicated question, but let's address it as best I can in the time remaining. If the patient has a profound systemic illness, particularly something that's life-threatening, clearly that comes first, whether it's a cardiac or it's cancer. Now, patients that are stable, that are symptomatic, that are fully informed about their medical status, as long as you don't put them at medical risk by operating, then if it makes them more comfortable in the last months or years of their life, it's still okay to operate. But we got to make certain that we don't add to their medical complications by doing lengthy procedures, putting the patient to sleep, or improperly managing them medically at the time of surgery. Now, thinking about ocular reasons, there's so many. The classic question is, how long do you wait in a vitreous hemorrhage? And they'll say, well, What's the condition of the retina? What does the ultrasound show? What's the vision in the other eye? What's the patient's occupation? What's their health? How old are they? What's their mental attitude? Does surgery make them nervous, or does losing vision in one eye make them more nervous? So there are many patient factors, medical, psychological, and the condition of the other eye. For example, a very, very dense vitreous hemorrhage when the other eye is 2200 from macular ischemia, you might operate a 2200, a very, very dense hemorrhage within a week or so of that hemorrhage occurring, if you know that eye to be a 20/30 eye, if it's far and away the better vision eye, so the patient can get back to work. But switch the situation, 20/30 in the other eye, now you've got a vitreous hemorrhage in an eye that was known to be 2200. You're not going to get them back to work by operating that eye, so you may choose to observe for a while. So I think that's important. Next question is, patient with cataract and VMT is undergoing cataract surgery, will you prefer pneumatic vitreolysis or Vitrea? Neither. I prefer to, if you have a proper view, fix the macula first. If there's 3+ NS or posterior subcap, do cataract surgery, being careful to measure the axial length from the pigment epithelium with low coherence interferometry, and then come back later and do the VMT. Next one, how can I induce PVD easily in a young patient? There is no easy way in a young patient, so what do? If you're a young myope and you get an inferior so-called round hole detachment, a non-PVD detachment, or an inferior temporal dialysis, I do a core vitrectomy, make no attempt to forcefully create a PVD. I put perfluorocarbon in the eye, a full fill, put them on topical difluprednate, Durezol, and leave the PFO in for 2 weeks. And when I go back in, and of course I laser the brakes, when I go back in 2 weeks later to take the PFO out, a PVD has been created by flotation from the PFO, and now I can remove the vitreous to prevent further traction to the retina. So this is a fantastic way to do it. Now, PVD creation should not be done by moving laterally with your cutter. It should be, you should pull back from the optic nerve head with vacuum only applied. So people say, what about the flow rate at 27? 27 gauge is just fine to make a PVD because you're using the cutter as a forceps, not a flow rate machine. You're simply capturing vitreous. If there's a flow, you're not doing it right. And you can't go right over the nerve head. Think Weiss ring, there's no vitreous there. So you go at the outer margin of the nerve head and pull straight back. If you move side to side, you put shear on the vitreous space. That said, in a young myope, it can be challenging, and therefore I don't do it and make more tears. I use the medium-term PFO method I described. What is the key to becoming a great vitreomacular surgeon? Visualization, hopefully with ingenuity going forward, but certainly with a flat contact lens. 2, steady hands. Don't drink coffee before surgery. 3, brilliant blue. 4, don't use scrapers of any kinds or picks. And it says, do I need to do ion pilling in this scenario? It doesn't say what scenario. So I already listed all the scenarios: vitreomacular schisis, vitreomacular traction, lamellar and full thickness holes, epimacular membrane, macular folds, and hypotony maculopathy. I do it in all of them. Well, that's my last question, and we have 5 minutes less. Unless others have questions, we'll finish at this point and thank all the listeners. Hopefully we'll do more of these going forward. Maybe we'll do a whole hour answering questions without a specific topic, but I thank you all for listening.
Thank you so much. I feel so close to my friends and colleagues in India. I've, of course, been there many times and have had many visitors. And it's a very special relationship that I believe I have with the Indian vitreoretinal community, as well as the nation. And my heart goes out to your country for the pandemic crisis that I know is so hard on so many people, especially people that are poverty stricken. And we feel bad for that. Let me share my screen and we'll get on with my talk here. Complex retinal detachments, there's no hard definition of what's a complex retinal detachment. So I've listed the 3 things that are more difficult for all of us: giant retinal breaks, PVR, and diabetic traction retinal detachments. And I'm going to take them in that order. And the notion behind the talk is, instead of giving history and statistics and showing pictures and videos, I'm going to list what I think are crucial mistakes people make that I see over and over and over again when people show videos and they call me on the phone and email me about their cases, or I'm visiting professor. So I'm going to list the mistakes that I see made over and over again, at least in my opinion, they're mistakes. And I'm going to list what I consider the essentials to doing a good job in these challenging cases. So with respect to giant breaks, the biologic problem is PVR, but the surgical problem is retinal slippage during the exchange process. We all know that Stanley Chang brought us liquid perfluorocarbon, which is absolutely magical to put the retina back where it belongs, and we're so indebted to Stanley Chang's work. So when you then exchange it for gas or silicone oil, often the retina will slip. This is technique driven, as David Wong has emphasized. If you're meticulous about the technique, you can get around it, but it means that you have to put the cannula at the interface in the far periphery, and that does lead to lens bumps. And if you do phaco and break the capsule, you've created another set of problems. So what I've used for all inferior detachments, as well as all inferior, temporal, and nasal giant breaks, is what I call medium-term PFO. We all recognize that perfluorocarbon was approved as an intrasurgical tool, not as a short or medium-term tamponade. I do not use the so-called heavy silicone oils. They create an inflammatory process. But what I've done for over 21 years in over 1,000 cases of retinal detachment is to leave the PFO in. Now, clearly that won't work for a superior retinal detachment, but for a temporal or nasal giant break, the patient can lie on their side. It works absolutely great. And there's no slippage because you're not exchanging it. For inferior, it's perfect because the patient can stand up, walk around, go to work, fly in an airplane, unlike a gas bubble. So I use this medium-term PFO technique for all my inferior detachments, but it's particularly advantageous for inferior temporal and nasal giant breaks. What are the essentials? I do not believe in using multiple spots of laser in any case. This is an anachronism that comes about from cryo or even diathermy where you can't move the probe. There's no reason for spots that are separated or multiple rows. You have a far more uniform adhesion between retina and RPE if you use confluent lasers. And the confluent laser sort of smears the thermal profile, so it evens it out, whereas a normal laser spot's hot in the middle and cold on the edges. Always excise the anterior flap. And this is analogous to what I'm going to talk about in retinectomy and PVR. Scleral buckles are bad news for these patients. They actually encourage slippage. There was sort of an insider joke years ago. Machamer would do a buckle on the PVR cases, write a letter, say the retina is substantially reattached. Yeah, that meant attached on the buckle, but not behind the buckle. People don't see with their equatorial retina. I'm sorry. There's an obsession with combined phaco. If you've got a 20-year-old, they're not going to get a cataract from vitrectomy. Nuclear sclerosis progression is the rule. Clear lenses remaining clear is the rule. So only use phaco if you can't see what you're doing. Do not use a short needle, a half-inch needle, to inject the PFO. It causes multiple bubbles, and they end up getting in the subfoveal space, which is bad news. If you use the Med1 cannula, which I did not invent and I do not have a royalty on, I have no financial interest in Med1. The Med1 dual bore allows you to have a normal interocular pressure because there's a fluid egress path, and now you can inject with this flexible polyimide cannula at the right level. And we'll talk about that, but in a moment. And excessive retinopexy, instead of saying this is a bad case, we got to do more retinopexy to hold the retina down. Don't do it. Cryo is terrible. It causes PVR and it causes slippage of the break. So when the dual bore cannula has an egress channel, and so you should start with the tip of the dual bore cannula at the optic nerve head, make a small bubble, and then keep the tip of that yellow cannula that you see there, the pale yellow transparent cannula, in contact with the top surface of the bubble, and slowly withdraw as you inject. If you do that, you won't waste this precious, expensive PFO, and you will have a full fill without multiple bubbles. I use only the Alcon for fluoron. As some of you may know, there was a batch of PFO from India that was toxic. I don't use perfluorodecalan. I don't have any evidence that the perfluorodecalan's bad, but the index refraction isn't as different as it's just not as easy to see because the index refraction. So obviously the subretinal fluid, as well as all infusion fluid and liquid vitreous, all floats to the top, and you want to get rid of absolutely every drop of that. So people say, oh, you mean I can do a full fill? You must do a full fill. Oh, I'm afraid to do a full fill. Why? What do you think is going to be the problem? If you fill it all the way to the back of the lens or the IOL, or in the pseudophakic eye, fill it almost into the anterior chamber, then you have less aqueous material, whether it's aqueous humor, or liquid vitreous, or infusion fluid left over at the end of the case to cause slippage. So full fill, mandatory. And this emphasizes that point with the word complete on the left. And you can see how as I finally filled it near the top, there's a very flat angle to this cannula, so the egress channel, and actually rotate the eye over a little bit so I get the last little bit of fluid out. And this shows the confluent laser that I emphasized, and the excision of the anterior flap was not well depicted there. What about superior giant tears? Well, you have two choices. You can exchange for oil, which you must do if there's PBR, or if there's no PBR, you do have the option of exchanging for gas. And but how do you do that? You don't have three hands. So you either use chandelier illumination, which has the problem of glare, but you can use the malleable Alcon one and aim it in the right place. I always use the Alcon VFC on the console at 80 PSI to inject. The other option that I only began to do recently is slower, but it allows you to do three port without a chandelier. And that is Med1 makes a PVC tubing instead of silicone rubber that snaps over a non-valved infusion Alcon infusion cannula. So that works real well, so that you can have the extrusion cannula in the other hand and the endoilluminator in one hand, and have sort of standard technique. So I tend now to use that method. I don't use it in PBR cases because it's much slower in terms of the oil injection rate than the method in the first bullet point. Again, it's extremely important during the exchange to do sort of the inverse of what I described with the injection process. And that is, and this, again, something that we must credit David Wong from Liverpool, and that's to keep the tip of the extrusion cannula right at the oil or gas interface with the PFO in the periphery. So there's a meniscus of BSS, subretinal fluid, and liquid vitreous there, a little thin meniscus. You want to get rid of every bit of that. What I've seen people do is put the soft tip cannula at the optic nerve during the exchange, and sure enough, the retina slips back, and now they're trying to manipulate it mechanically and bumping the pigment epithelium and causing PBR or having to start over. So it's very, very important to do this exchange properly. This is where mistakes are made. To do that, you must focus down. I use only Ingenuity for visualization, but whether it's Ingenuity or the microscope, you must use the highest magnification and follow focus. I used to work in TV. I put my way through engineering school being a TV engineer, and we call it follow focus. So you follow that interface between the PFO and whatever you're exchanging for, gas or oil. So you keep that extrusion cannula tip at the interface as it moves down, again, in the periphery, because the fluid meniscus is thicker in the periphery than it is centrally. So you don't want to be at the apex like you are when you inject. So this shows you that technique of exchanging and removing all of this BSS. Now let's switch gears and talk about PBR, so I don't run out of time. I invented retinectomy exactly the same time Macomber invented relaxing retinotomy. And we presented at the same meeting in Los Angeles. Often Macomber is credited with inventing this because of his prominence in the field, but in fact he didn't. But what matters is not who invented it, but how to do it properly. What's the difference? There is a substantial difference. Macomber made a circumferential cut and left all the tissue anterior to it. If you look at the silicone oil series, there was a 22% incidence of hypotony. That is absolutely caused by bad technique, namely heavy cryo, buckles, and more importantly, leaving this anterior tissue. So when you make a circumferential cut in the retina, excise everything anterior to it, just like in a giant break, you excise the anterior flap. If you leave that tissue, for one, if it's anterior to a cut, you can't see with it. The notion, well, it might cover the pigment epithelium. It doesn't. It scrolls up and it covers the ciliary body and causes a point Machamer made. Machamer from German used the language Ringschwelle, and that's residual capsule, cortex, peripheral vitreous, anterior retina, all in one ring that runs around the eye. That's what leaves the epiciliary tissue. I polled my ex-fellows via email and asked them, how often have you seen hypotony from my PBR cases? Not one person could remember a single case. And I go to meeting after meeting where they talk about endoscopic surgery to remove the tissue on the ciliary body. Doing Machamer's relaxing retinotomy technique is a major cause of that. It also causes more PBR, as John Lean and I have reported. Don't do a scleral buckle. Scleral buckles, patients pay money for, or it doesn't, even if they don't pay money for, it doesn't matter. They want a good refractive outcome. You induce around 3 diopters of axial myopia when you encircle. There's no randomized trial evidence that a buckle improves the outcomes in PBR. Day in, day out, I reoperate other surgeons' PBR cases that they send me or somebody else sent me, and there's a giant buckle in the eye and all the retina is detached posterior to it with PBR all over it, and the breaks are posterior to the posterior edge of the buckle. It makes glaucoma filtering procedures a nightmare. It causes ocular surface disorders. It causes strabismus. I've done 8,000 vit buckles, but I got over it and I learned not to do it anymore. And I haven't been doing buckles, period, for around 15 years and maybe more. And that's important. So if you do a lensectomy, don't leave the capsule because you're going to put a sulcus lens in later. The capsule sticks to the back of the iris. They get a concave iris. They have more epiciliary tissue and more hypotony. Excessive retinopexy causes PBR. Don't say, oh, this is a very challenging case. I got to do 6 rows of laser. Don't do it. If PBR comes back, don't take the oil out to reoperate. I've reoperated all my PBR and epimacular membrane cases under oil for over 30 years. It works absolutely great. It takes a short amount of time. It's less traumatic on the eye. There's many, many advantages to reoperations under oil. I've seen patients that have PBR with oil in the eye, recurrent PBR. The doctor takes the oil out, puts PFO in, which promptly goes underneath the retina, and then at the end they put the oil back in. What are they thinking? What's that PFO step supposed to be for? There's absolutely unnecessary to do that. Sorry, let's go back one. So what's the sequence of events? You always initiate in any detachment case internal drainage subretinal fluid, which I invented, before you do fluid air exchange. Always drain first. Then as the retina goes back under air, it may hang up and you say, oh gosh, I missed some vitreous. Don't start over and put fluid in the eye. Do vitrectomy, interface vitrectomy under air. Then you go farther back. You say, oh, there's a star fold I missed. Let's peel membrane under air. Then the retina goes farther back. Oh, the retina's, now that I see it, the subretinal fluid was turbid. I couldn't see it before. Now some of it's removed. I can see there's a subretinal band. Let's remove it or resect it. Then as you finally get back farther, that's when retinectomy is performed under air. Don't do retinectomies under saline. That's important. So I call this generically interface vitrectomy, under air, under PFO, or under oil. Now we know obviously that air and oil float, so the word under is in quotes. But what are the scenarios? One, the one I just described, where you notice traction during fluid air exchange. 2 is if you noticed it after you put PFO in. I often do some more vitrectomy in the periphery with PFO in the eye, being careful not to be in the PFO space and remove it. If the retina is highly mobile, jumping around, making you nervous during vitrectomy, and this is much less common with the 10 and 20,000 cut per minute cutters. But anyhow, if that point you can put air in and it'll work. If you have bleeding and traction detachment surgery that just you can't seem to stop it by raising the pressure, put air in. The bleeding will be confined to the retinal surface, and you can at least finish the vitrectomy under air. All retinectomy should be performed under air, not PFO. And then, as I said, all silicone re-ops should be done under oil without taking it out. How do you do that? If it's a epimacular membrane, you don't even have to add oil. If there's a subretinal fluid, then obviously you've got to inject oil as described here. And this shows you membrane peeling under oil. And this shows you an epimacular membrane under oil, and you just top up the fluid if there's a little shortfall. What about diabetic traction attachments? We only got a few minutes left, so I'll talk quickly. The notion that there's a linear algorithm, first do a core vitrectomy, then make a PBD, then do membrane peeling. That algorithm, one, is way too rigid and has nothing to do with diabetic traction attachments. Don't do forceful PBD creation. It causes iatrogenic retinal breaks. And membrane peeling is totally unnecessary. So what do you do? Well, scissors delamination and cutter delamination are what you should do. The second common mistake I hear over and over again, people say, oh, with today's multipurpose cutters, there's no need for scissors anymore. And I said, well, how often do you put in oil? Well, these, are complex traction attachments. I usually use oil. What are they telling you? They're telling you they made iatrogenic retinal breaks. If there's no retinal breaks, there's no need for oil. If you're using oil commonly in diabetic traction attachments, frankly, you're not doing a good job. So you must use curved scissors in addition to the new beveled cutters. The cutters are way better than they were even 5 years ago. I love the Alcon 20,000 cut per minute bevel cutter. I can do more and more epiretinal membrane, but not all. You must have in your armamentarium the ability to use curved scissors for delamination. It's an essential. Don't use diathermy before cutting things. Wait until you delaminate with the cutter or the scissors. If it bleeds, elevate the pressure. If it doesn't stop, then use the laser for hemostasis. And there's absolutely no need for a buckle in these cases or for viscodissection or bimanual surgery. If you use disposable scissors, which means you then won't contaminate and cause toxic posterior segment syndrome from bioburden, then the scissors work well, and I find no need for bimanual surgery to stabilize. Bimanual surgery is not necessarily bad, it's just unnecessary. There's two types of delamination: fold back for flexible membranes and conformal. And this is what they look like. So if it's a rigid membrane that won't fold back, you've got to put the port right at the margin of the epiretinal membrane. You can't pull it up into the port. If it's flexible, you can put it on top of the membrane, behind the edge of it, and it will fold back into the port. Both those work, but they're for different. This is, rigid, flexible. So when do you need scissors? When the membrane's adherent to the macula, that's the tabletop traction attachment, typically, or if the retina is very thin and atrophic, which is more often nasally or in mid-periphery. So if it isn't necessary to remove every bit of epiretinal membrane outside the arcades, but if there's membrane that's causing the macula to be elevated or folded, then you got to do something about it. And if it's adherent to very thin atrophic retina from ischemia or from a chronic TRD or from prior PRP, then use the scissors, because if you use the cutter, you're going to make iatrogenic retinal breaks. Why is silicone oil bad? Because it has a very low oxygen extraction ratio. It confines cytokines like basic fibroblast growth factor and VEGF, and causes Mueller cell reactive gliosis at the retinal surface. When should you use vertical scissors? Never. Curved scissors are better for everything. The back wall of the eye is curved. Vertical scissors require more space to get in the potential space between membrane and retina. Always use curved scissors. What's segmentation for, which I invented? It's for access to the delamination plane by and large. Should you stick it in and open them? No. Should you stick the scissor tips in wide open and then close? No. Make small snips. Don't do this. Don't spread. You'll tear. Make small snips at the margin as depicted here. What's the direction of delamination? Inside out is better. Start at the nerve, delaminate along the arcades. The retina is stronger. You can see what you're doing. The surgical planes are more visible there. Outside in causes more breaks. There's room for outside in on occasion, but instead of starting at the outside edge, outside the arcades, where you're more likely to make a retinal break, start at the nerve head and delaminate outwards in most instances. This shows you inside out delamination with a 25 gauge curved scissors, and this shows you removing the sheet. This makes the point that instead of you must make a PVD first, then deal with the retinal surface is wrong. If there's not a PVD, don't worry about it. Go centrally, delaminate inside out, and the outer margin of epiretinal membrane will be contiguous with the posterior vitreous cortex, and you can safely remove it then. Where does this fit? If there's no PVD, don't make one. Delaminate inside out first. It was called en bloc by Gary Abrams and a number of others in Milwaukee at the time, and en bloc is a stupid term and a stupid concept because the original en bloc paper by them, I invented delamination, and I invented delamination before the PVD if you don't have one, but they went ahead and published it, put a different name on it, en bloc, but they were wrong on what they advocated. They said use the posterior vitreous cortex to pull on the membrane, which is a very bad idea. And the en bloc comes from cancer, where the point is to remove it in one piece. That's what en bloc is translated from. That means in a block, one piece. That's not what you want to do, because you're going to create remote traction. So it's very useful to do segmenting the delamination, segmenting into a couple pieces as you delaminate, so you're not pulling on the supratemporal arcades or the fovea when you're working on the infratemporal arcades, as an example. Peeling has no role. If it happens, just come off easily, fine. But don't start with picks and manipulators and spatulas thinking you can peel. Peeling's for macular surgery and PBR. And lastly, don't use diathermy for hemostasis. Use the laser. I published this years ago. The green 532 nanometer laser energy is absorbed in the hemoglobin blood column, which obviously green light's absorbed in red. This way, the energy is confined to the blood column, whereas there's collateral damage with the radiofrequency energy of diathermy. Well, that's all I wanted to cover. I guess I didn't run over with time, but about 2 minutes. I guess we're okay. So thank you so much. Hi, I'm Steve Charles from Memphis, Tennessee at Charles Vitrectomy Institute, and I'm going to talk to you today about trauma. I managed a considerable number of trauma cases in the first half of my career, not so much in recent years, but I've noticed some common errors and some tips and tricks that will help us get better outcomes and decrease operating times and so on and so forth. So let's switch now to my PowerPoint and we'll take a look. So I think it's very important to understand that trauma is not different than PBR. What is PBR? PBR is excessive healing. It's excessive repair. And one of the common themes of mistakes made in trauma management is doing excessive retinopexy. And we see this over and over and over again as a theme of cases. Example, the foreign body strikes the retina. There's a little retinal whitening, and the surgeon decides to put 4 rows of laser around it. Much larger scotoma, much larger scarring afterwards, simply an error. The patient has a corneal scleral laceration that extends into the retina, and the surgeon applies, particularly the initial repair, applies cryo all along the edge, absolutely inviting fibrosis, scarring, and which is, again, the same as PBR. Remember that all layers repair themselves. The retina, the sclera, the choroid, the RPE. It's fascinating to me that there's this obsession in earlier years with fibrovascular ingrowth. We must explore all the posterior wounds and sew everything up, because otherwise scar tissue will grow through the wound into the eye. This is simply nonsense. And numerous eyes have been ruined by somebody's attempt to explore. I do not recommend 360 porotomy and trapping all the muscles and exploring in the cases of these double penetrating injuries or corneal scleral lacerations extending posterior to the ora serrata. So please remember that this fibrovascular ingrowth is a massively overrated phenomenon, and the trauma to the globe and the unintentional extrusion of vitreous and retina out the wounds in an attempt to explore, to somehow prevent this uncommon event, or rare, if ever, event of fibrovascular ingrowth is something to bear in mind. Scar tissue never invades vitreous. So when I hear people say, oh, the vitreous is getting organized, the hypocellular gel contraction does occur, but it's largely around the surface of the vitreous. So remember that as a foreign body or a, for example, a nail, a needle travels through the vitreous cavity, now there's a new surface, and that surface can certainly proliferation can occur on that surface. But two common themes. Please put to rest this notion that we must do a 360 porotomy, explore the globe, and freeze along the wounds in order to prevent fibrovascular ingrowth. Simply a bad idea. And that when a foreign body strikes the retina, whether it's an exit wound or it's that we must do rows and rows of laser around it. This is simply excessive and leads to fibrosis in the broader context of PBR. What about cyclitic membranes? They require a substrate or a scaffold, as some call it. And so that can be fibrin. It can be the posterior lens surface, lens capsule. It can be the anterior vitreous cortex. So another common error is leaving the capsule so that you can later put in a sulcus interocular lens. I say jokingly, patients go to the hereafter without an interocular lens in their eye, and it's okay. There's just too much emphasis on we must put in a posterior chamber lens. No, we must save the eye and reduce the chances of PBR and cyclitic and hypotony and ptysis bovi by taking all the capsule with forceps. So if you take the lens, take the capsule. What often happens if they leave the capsule in this well-meaning attempt to put an IOL in later is the capsule becomes adherent to the posterior surface of the iris, and this becomes a scaffold or a substrate for epiciliary tissue, which ultimately leads to hypotony. This old notion of a ciliary body detachment, which is not a detachment at all, it's simply edema, somehow causes, I apologize for the page in my office, leads to hypotony is simply incorrect. That does not happen. So what cells can participate in this proliferation along this frontal plane where the back surface of the lens used to be? Well, sclera, episclerotenons, RPE, Mueller cells, all of these, and cells that originally of hematologic origin can all grow. But once again, it's rarely ingrowth. It's usually not tissue ingrowth. And it's not caused by hypotony. I've had patients, numerous patients, the pressure's 3, 4, 5, and people say, oh, what are we going to do? They might get a cyclitic membrane from hypotony. Again, low pressure doesn't cause hypotony. Necrosis of the ciliary body from endophthalmitis leads to it. Epiciliary tissue from unwise leaving of the capsule and leaving of peripheral vitreous on the retinal surface, that epiciliary tissue leads to ingrowth. For example, in the PBR context, I've always recommended retinectomy, unlike what Mockemer recommended of relaxing retinotomy. Why? With relaxing retinotomy, you leave tissue anterior to the circumferential cut, but with retinectomy, you remove it. If you remove it, you have less epiciliary tissue, less hypotony, less cyclitic membrane growth. The late Robert Mockemer used to use the term from German, Ringschwelle, and not being a German speaker, I can't directly translate it, but the notion behind it was this complex of posterior iris surface capsule, what I call neocortex, peripheral vitreous, and elevated peripheral retina, that this is what leads to a concave iris, and it leads to epiciliary tissue. And if there's a substrate, so a tissue can grow across the eye in the frontal plane, can lead to a cyclitic membrane. So try to think about reasons not to put an IOL in an acute trauma situation, and never leave the capsule if you do a lensectomy, and try to remove as much and when you remove the capsule, don't do it with the cutter, use forceps and literally tear the zonules in a circumferential fashion, much like you're doing a rexus, so that you get all the capsule. Don't just make a hole in it with the vitreous cutter. These are very important concepts to prevent these terrible situations of hypotony and ptysis bulbi. So to repeat some of this, hypotony doesn't cause ptysis. Cyclitic membranes cause ptysis, this contraction in the frontal plane through the ciliary body. But the low pressure can be from a non-apparent wound leak. It's really common for people to do Seidel testing and say, oh, there's definitely not a wound leak. And then if you explore more carefully under the microscope, you'll find that, in fact, it is a wound leak. Now, destruction of the ciliary body from endophthalmitis or very severe trauma can certainly cause low pressure, but it's not from detachment of the ciliary body, as I said earlier, and I think that's important to bear in mind. I've had patients sent to me with the low pressure and a post-trauma situation saying, please do ERG to see if this eye is viable. ERG doesn't work if you had an opening in the wall of the eye, because now you can't create a voltage gradient compared to the outside to the inside of the eye. And so it's simply, ERG is completely useless in this trauma situation, but there are people who have this idea that it somehow tells us viability of retina. If you have a 1 second old total rhegmatogenous detachment, there's a non-recordable ERG. And so the ERG is totally useless in this situation, yet some people have this misconception that it somehow teaches us viability of retina. Total detachment equals non-recordable ERG instantaneously. It's not a viability test. So when should you operate? This is a debate that's been going on forever and ever. So what are the trade-offs? If you try to do a pars plana vitrectomy in an acute situation in trauma, there's usually not a posterior vitreous detachment. So now you have an issue about with necrotic retina. Am I going to try to tug in the vitreous, create a PVD, and potentially make many more retinal breaks, some of which can't even be visualized because of hemorrhage on the retinal surface? Or am I going to leave that posterior vitreous cortex there and risk reoperation? I tend to go the other direction and say, I'm not going to make an acute PVD. But unless you're concerned about infection, about endophthalmitis, or about toxicity from ferrous or copper from either chalicosis or siderosis in the acute setting, unless you're worried about that, it's better to wait some period of time. What's that period of time? That period of time is somewhere in the 7 to 14 day region. Usually a PVD occurs during that time, but there's another way to determine should you operate. I'm the inventor of real-time grayscale ultrasound. Why did I want to do real-time as opposed to taking snapshot pictures? I wanted the patient to move their eye up, down, left, and right to see about vitreous mobility. Often I'll see in the chart, no view of fundus with indirect ophthalmoscopy, no view of fundus. It's not if you can't see the retina, look at the vitreous if you can't see through it and see if it's got mobility. If the vitreous flows around like seaweed in the ocean with the waves going in and out, that's a good thing. If it starts becoming rigid, whether you notice that on real-time ultrasound by having the eye move left and right, up and down repetitively, or you see it with indirect ophthalmoscopy, that tells you that proliferation is occurring in the vitreous cavity and you better get on with vitrectomy surgery rapidly. That's typically 10, 12, 14 days, although it's not a fixed rule. Some people say that it occurs earlier in children. It's a bit harder to prove, but probably the case. The notion that when you do ultrasound, you should send it to some technician who has the patient in a sort of a programmatic way, fixate on this target of the ceiling. Now, please don't move your eye. Absolutely wrong. You want the patient to look all around, left and right. For one, you're sampling with a small slice, and this decreases your sampling area. You're just making slices through more regions. Secondly, you're facilitating your brain taking these two-dimensional slices and integrating them into a 3D volume. Instead of some script like look up and left, look up and right, I want to move the B-scan probe side to side, then up and down, saying, oh, well, when I point the ultrasound toward the top of the eye, the retina is detached. When I point it toward the bottom of the eye, it's not. When I point it temporally, it's detached. Oh, okay, I got a supratemporal detachment. So that's how I do this reconstruction. But once again, I love it when the patient moves their eye around. So I have less sampling here, a greater capacity for spatial reconstruction in my brain, and most importantly, in the trauma context, is assessing the mobility of the vitreous. This is absolutely crucial. Measuring the IOP to determine when to operate has no merit at all. So it's all about vitreous mobility. Once you get past the cases that must be operated very rapidly after trauma to prevent endophthalmitis, and we'll talk about those in just a moment. So if it's a ferrous or copper foreign body, especially if the foreign body is seen to be near the macula, toxicity occurs very rapidly, hours, and it's from free iron, which I published with Doug Anderson, which causes damage to the axon receptor terminals of cones and rods, and then any plant, animal, or human biologic materials, so dog bites and injuries at a horse farm or in an agricultural environment, or South Florida, a cactus, a needle sticking in your eye and such things. These you must operate very rapidly. If the patient's seen at 8 o'clock at night, does that mean at midnight, or does that mean first case in the morning? That has to do with logistics and availability of equipment and trained personnel, and as well as the medical status of the patient. Obviously, they need to be MPO for general anesthesia, and you need to have a crew that's trained where all the equipment is available that you need. Sometimes cases presenting very late in the day or evening, it's better to operate the next morning simply to get it right. But there is always the risk that endophthalmitis will proceed. So if you delay surgery, of course, Harry Flynn at Bascom Palmer has more expertise in this than I do, but if you must delay the surgery for systemic medical reasons or logistics reasons, then you must consider subconjunctival or intravitreal antibiotics. And I'll leave that discussion to Dr. Flynn. If you preserving the lens is nice in young people that are not presbyopic, but it shouldn't be an impediment to proper care. If you have plastic, glass, or lens material in the eye, so windshield pieces, plastic pieces from pieces of plastic blown up, those are non-toxic, and they have very little endophthalmitis risk because bacteria are typically not adherent to them. And again, that's not a rule. You got to use your clinical judgment. So let's move on a little bit with the problems with acute vitrectomy. So those who advocate I've heard some say all patients must be operated immediately if they've had trauma. I don't buy that. And so what are the reasons not to do that? One is arterial bleeding, typically not a blood clot. So as soon as you decompress the globe a little bit by making an incision, you can have a bleed. They can bleed post-op. And then wound leaks are another issue. It's just hard to acutely close all of them. Fibrin helps you seal wounds even hours and days after surgery, but often if you operate immediately, you'll have more wound leaks. And then there's always the risk of choroidal and suprachoroidal hemorrhage, both choroidal edema and suprachoroidal hemorrhage. And this can be a serious issue if you're not careful with infusion cannula placement, because many suprachoroidal infusions result in suprachoroidal hemorrhage, which that gets blamed on the case when in fact it was inappropriate placement or inappropriate maintenance of the proper position of the infusion cannula. This is very important. If you've had a corneal laceration, often there'll be stria pointing toward the wound, no matter how careful you are with 10-0 nylon suture centrally or 9-0 in the mid-periphery, and it'll just be a challenge to see what you're doing. Obviously, a contact lens is better than non-contact visualization because it smooths out the induced astigmatism from the corneal wound. And I mentioned earlier this business about posterior vitreous detachment. The conventional reason to wait is to give time for the posterior vitreous detachment to occur, so you can do the so-called instant re-op by removing all the vitreous that you can at the initial procedure, instead of having to go back because there's residual posterior vitreous cortex causing traction on the retinal surface. Let's talk a little bit about how to repair the wound. I've noticed that there's a trend, and some of the ophthalmic plastic surgeons are so obsessed with taking photographs that there'll be this notion that you explore the whole wound. You open the peritomy 360, which I never do, expose the entire wound in the sclera, measure it, take photographs of it to document it. This is not about documentation, it's about surgery. So squirt safe BSS on the surface of any apparent wound to wash away fiber and foreign materials. That'll help you visualize. If there's any viable uvea sticking out, reposit it with viscoelastics. I prefer viscoat. And then close what you see. Don't explore the wound. Once the part that's exposed is closed with nylon sutures in the sclera, or 9-0 in mid-cornea, 10-0 in central cornea, once it's closed, then you can look at the two ends of the wound, obviously the posterior end being the important one, and start to explore to see, does the wound extend posterior. But don't open conjunctiva and tenon and expose the entire wound because you're trying to take a photograph of it or assess the situation. You risk an expulsive hemorrhage. You risk vitreous and retinal prolapse out the wound by exploring. So again, sequentially close what you see, then explore. Never, ever, ever touch cellulose sponge to the wound. You'll pull vitreous out. I remember a trauma case years ago when I first moved to Memphis. Some trauma expert from the military showed up and disagreed with me, and he was an attending, and he said, "Oh, you must explore." I said, "Please," to the residents, "leave this eye alone." So they went to the operating room anyhow and listened to this so-called trauma expert from the military who took cellulose sponges and cleaned up the temporal vitreous, pulled the entire nasal retina into a giant break situation, and sutured the nasal retina into the temporal wound and declared a success. And then when I looked at it, they said, "What's wrong with the fundus? The vessels look funny." I said, "Well, the retina's upside down because your attending sutured the nasal retina into the temporal wound." So that was a case that simply needed time. It needed time to heal the temporal sclera. It will heal on its own. But cellulose sponges are absolutely taboo. Please never, never touch wounds with any vitreous in the anterior chamber, or touch the wound posteriorly with a cellulose sponge. Because of wicking and because of the need to lift and cut, it invariably causes acute vitreoretinal traction. And never apply cryopexy to these wounds. It's simply a bad idea. You've got a trauma wound already. It's going to be repaired already by the body, by biologic processes. And if you add further tissue destruction, you increase the risk of fibrosis and even exudative retinal detachment, and you increase the risk of PBR. So stay away from cellulose sponges and cryo. What's my argument against exploring posterior to the equator? The risk of fibrovascular ingrowth, as I've said repetitively in this discussion, is greatly exaggerated. If you explore posterior to the equator, you often cause vitreous and even retinal prolapse, which is a much higher risk for the eye than fibrovascular ingrowth. Placing traction sutures under the rectus muscles can result in these muscle hooks penetrating the eye. This is the most common site of rupture, is this very thin sclera at the muscle insertion site, and it's just simply a bad idea. And just doing a 360 peritomy, which often in this acute trauma situation results in poor closure with overlapping of conjunctiva in the cornea, results in ocular surface disorders, some blepharon, even strabismus, post-op swelling, discomfort, and you got longer operating times. And sometimes these patients have been in car wrecks and have multiple organ system trauma and fractures elsewhere in the body, etc. So when I hear people say, "Oh, it's a tough trauma case, I did a 6-hour surgery," you did the wrong thing. Simply don't do that. Close what you see. Don't do peritomies, and then do it sequentially. Close what you see and then see the posterior extension and then close that. And once again, stay away from cryo and stay away from cellulose sponges. Big mistake. What about viscoelastics? They are your friend. Anytime there was a corneal laceration, I always put air in the anterior chamber. In the old days, people say, "Oh, air is toxic to the endothelium." Really? Please look up how you do DMAC or DSEC to replace the corneal endothelium. Routinely, an air bubble, gas bubble is placed in the anterior chamber to hold the endothelial graft in place. So clearly it's not toxic. We now know that. But at any rate, air was an excellent way to hold vitreous back, to hold iris back, and to and through surface tension to manage these stellate wounds in the cornea that are hard to repair without leakage. But as soon as viscoelastics, particular visco, became available, it's an excellent tool to maintain the anterior chamber. If there's a chance of maintaining the crystalline lens, the natural lens, that's a good thing. There you have less astigmatism because you can have a nice controlled interocular pressure while you're suturing the wounds, and you can find bleeding. You can actually do viscodilation of the pupil and gently move the pupil, the iris, away from the anterior lens surface using viscodilation, if you're careful not to physically touch the anterior surface of the lens. So there are many, many advantages. So anytime you're repairing the anterior chamber, please fill it with viscoelastic. And don't worry about irrigating it out in the end. This isn't cataract surgery. Just leave viscoed in the end, and it will keep the chamber formed. That can't be done with other viscoelastics because there could be pressure problems post-op. You can always leave a little limbal incision and then burp that incision post-op if the viscoelastic causes a pressure increase on the first post-operative day. So some of the trade-offs that I've alluded to over and over again are, let's go through the do's. Close the exposed wound, then explore. Trim the vitreous flush with the inner wound margin with the cutter, or use the Van Ness scissors and irrigation. Don't lift it up with the cellulose sponges. And with the central cornea, you should use 10-0 nylon or even the middle of the cornea. But if you're going to perform a pars plana vitrectomy, trying to use only 10-0 to not induce astigmatism can be problematic, because when you use the trocars to place the cannulas and you manipulate the eye to rotate it and see the periphery, you can cause wound leaks and iris prolapse, or even if it's posterior, you can cause retina and vitreous prolapse even more seriously. And again, avoid this porotomy, avoid cellulose sponges, and don't use absorbable sutures in the sclera. It's simply a mistake. Nylon is the one and only suture to use for sclera. Why? If you push on the eye and the wound comes apart a little bit, it's elastic and it'll close it. The absorbable sutures stimulate further inflammation. That's how they absorb. They don't disappear into thin air. And so that's also a very bad idea, but a commonly done idea. So don't use Vicryl to repair the sclera. So some of the common mistakes, I've seen patients that were managed by really, really wonderful ophthalmic plastic surgeons that did an inadequate job of managing the globe. A case comes to mind, a really wonderful young boy got kicked in the face by a horse. It was a patient from Ohio I saw my first several years in practice. And the maxillofacial people operated in the plastic people. And so he went from, a Lefort 3 with the blowout fractures and everything to have all that fixed. And then finally somebody got an eye exam and he was icicle in both eyes and blind. Just a huge mistake. So I get it that you want to have up gaze and you have to fix blowout fractures, and people don't like bony deformities of their face, and these are important, but vision is even more important. And so close attention to the globe and not having, the maxillofacial surgeons or plastic surgeons manage the patient is very, very important. There's an obsession with interocular lenses. I've seen patients that had a vitreous hemorrhage, a corneal scleral laceration, and at the initial repair, somebody put an IOL in, which was at a 90-degree angle the first post-op day to the iris plane, with its one haptic sticking back into a vitreous hemorrhage, and the patient had a retinal detachment behind it. There are phaco IOLs, a wonderful operation for cataracts, but it's not the right surgical procedure in many of these trauma settings. The capsule is often disrupted, so now with phaco you can encounter vitreous and apply traction and cause giant breaks, or at least other retinal breaks that were not present before. This notion that hypotony is this horrible thing and everybody worries about it and they say it's inoperable. If they got hypotony, fix it. Do a vitrectomy, put oil in the eye. Explore the wounds, fix the wounds. And remember, there's no such thing unless a huge trauma occurred of a ciliary body detachment. Obviously, you can get a cyclodialysis, but a cleft can occur from blunt trauma. Another common mistake is this excessive exploration we've talked about many, many times, and we've talked about cellulose sponge and cryopex being bad ideas. Temporary epicardial prostheses are overused. If the patient has an opaque cornea, if you put a cornea that's going to be rejected back on there, that's not a good thing. If you put their opaque cornea or semi-opaque cornea back on, that's not a good thing. But you limit access to the periphery when you're trying to operate through the pars plana, when one of the main goals is to avoid epiciliary tissue. So if I require a penetrating keratoplasty, I use general anesthesia, and they must have neuromuscular blockade so they can't buck on the tube. The anesthesia people might push back and say, oh, let's use an LMA. And I say, no, this patient needs general endotracheal anesthesia and they need neuromuscular blockade. Well, it might take 10 minutes longer to wake up. Who cares? Let's do a penetrating keratoplasty, and then you can see the ciliary processes. You can remove peripheral foreign bodies and peripheral vitreous and hemorrhage, and really have access to the ciliary body surface, and then fill the eye with oil, put an air bubble on top of that, and sew a button back on and do if a penetrating keratoplasty is required. I've done over 400 cases that way. It's very, very effective. I can do that in an hour, hour and a half. Even when retina is stuck to the back of the cornea, I can dissect it away, access the subretinal space. So in short, I much prefer open sky vitrectomy to this excessive use of temporary epikeratoprosthesis. I've seen numerous op reports where the patient's surgery took 4, 5, 6, 7 hours. The eye is totally inflamed. PBR occurs, within weeks afterwards, and so there's an excessive use of temporary epikeratoprosthesis in my temporary keratoprosthesis, rather, at least in my opinion. What about iris retractors? Viscodilation is better because the trauma that iris retractors produce causes inflammation. So if you can use viscodilation of the pupil, I prefer that. I used to, because our vitrectomy technology was pretty poor, 400 cuts per minute, inadequate control of vacuum back 35, 40 years ago, I used to encircle all these eyes. That is the last thing you want to do. For one, you induce some unknown amount of axial myopia, typically about 3 diopters if you encircle. 2 is breaks often occur posterior to these narrow encircling bands people use. And 3, you cause excessive trauma to the eye and symblepharon and strabismus and pain, post-op pain. So in an acute trauma management situation, scleral buckles are just inappropriate and shouldn't be used at all, in my opinion. I've forgotten that I had this one slide in here about the temporary keratoplasties. So let's just review and see if I left anything out. If you have a very large foreign body, don't remove those to the pars plana. Really large pars plana incisions we did in the old days, they weren't a good idea. It's far better to remove them through the cornea. So a great big piece of metal penetrates central cornea, penetrates lenses in the vitreous cavity. Do a penetrating keratoplasty, take out the lens, open sky, do open sky vitrectomy, take this very large foreign body out through this corneal opening, and then sew hopefully a good button in place. And I think this is a great idea. I think we've discussed this enough already. Well, in open sky, let me add one more thing here. This bottom bullet point on the left-hand side here. Open sky vitrectomy facilitates bimanual surgery. You can orient the tools properly. You can gain access to the ciliary body surface and peripheral retina much better than you can with the pars plana vitrectomy approach. So, now, I know others would advocate in this situation endoscopic surgery. I don't have sufficient experience with that to really comment. Some excellent surgeons are using endoscopic surgery in this situation, but remember, how do you follow that patient postoperatively if the cornea is opaque? And ultimately, they're going to need a corneal transplant anyhow. So, but certainly there is room for endoscopic surgery in the situation of vitrectomy being required and the cornea being inadequate for visualization. So, again, others with more experience should lecture on that approach. One of the things we learned early on, the late Ron Michaels and I emphasized this many, many times, is the notion of the one compartment eye is a more stable eye. Stability is a bit of a vague term, so let's increase the sort of science behind that thought. If you take the lens out and the capsule and the vitreous, topical medications like steroids and non-steroidals now can access the vitreous cavity. If you have a 2-compartment eye, whether it's the natural lens or the IOL, any drop you apply to the cornea, the drug level in the vitreous cavity is 1/100th as much. So that's a big deal. Far more importantly, you want to think about the source and the target of both cytokines and cells. If you have a one compartment eye, it facilitates clearing of basic fibroblast growth factor and as well as fibronectin and so on and so forth, as well as various cytokines that result in PBR. I remember years ago, Mark Blumenkranz called the vitreous in the study the mitogenic milieu. Yeah, that's a good thought. There's more fibrin syndrome with the two compartment eye. So instead of thinking I must, the patient got a traumatic cataract, I must do a phaco and IOL, think about the benefit of a one compartment eye with no capsule, the iris functioning normally, no residual lens material, and then later on when the eye is completely quiet, you can do a sclerofixated or an anterior chamber lens, and these patients do just fine. But trying to do all that at one time and now having a two compartment eye with vitreous hemorrhage and glial cells and RPE cells, a Mueller cell reactive gliosis is another issue. Having these contained in the back of the eye behind an IOL is a very bad mistake. It's also a challenge in an acute trauma situation to determine proper fixation of the IOL because the angle, iris, and capsule are all damaged. So again, I discourage people in these severe trauma cases from doing phaco and IOL and encourage you to do lensectomy and to take the capsule with forceps and worry about the correction of aphakia later once the eye is completely quiet, inflammation is gone, hemorrhage is gone, and you've reduced the chances of PBR and hypotony, cyclitic membrane, etc. Iris retractors, as I've said, because they mechanically traumatize the iris, every time the pupil's small, our fellows want to pop in the iris retractors. I get it when you need to do that in cataract surgery. This isn't routine cataract surgery. Viscodilation is a very effective tool, and you should have this in your armamentarium. Use a side port blade to make a little limbal incision in the cornea, in clear cornea, and then put Viscode in the anterior chamber, and always start injecting on the far side and move the cannula back toward the wound that you made so that you make a monolithic mass, if you will, of this viscoelastic. Don't do it like you're decorating a cake, because then you have all these interfaces within it that are both optically challenging as well as can have blood products retained, and it works really, really well. If you have a small pupil, but wide-angle visualization, particularly contact-based wide-angle visualization, will usually allow you to see the periphery. This isn't about making videos. It's about fixing the patient. And so you don't have to have a 9mm pupil to do surgery. I've done many, many, many vitrectomies through 3mm pupils by using contact-based wide-angle, which gives you a 10-degree greater field of view than non-contact visualization. What about the disadvantages of buckles? I've already said I advise against them because they induce axial myopia, but in these young males that are the most common group that have cohort that have trauma, you might have 50 years to live, 70 years to live, and you're going to have intrusion of these narrow bands people tend to use into the eye. 50% increase in phoreas and tropias from the Ron Michaels, Bill Smitty paper many years ago at Wilmer. And also, if there's any trauma if you trap the superior rectus muscle, there's typically some levator-ponerosis damage and just a little bit of ptosis, a 0.5 millimeter, which is annoying to patients, particularly women. And then there's more pain and there's more pressure on the globe and much longer operating times. So once again, I would like to discourage the use of encircling bands. What about endophthalmitis prevention? Delayed vitrectomy is the biggest cause of post other than the initial incident, damaging incident. So a patient comes in mid-afternoon and you say, well, we can operate tomorrow morning. CDC says not to use antibiotics, so maybe I shouldn't. And then the next morning you look and you've got a hypopion and bad endophthalmitis situation. So think through if you've got any, what are the vitrectomy advantages? You can't sterilize the eye with vitrectomy, but you certainly can reduce dramatically the bacterial and fungal load, as well as removing bacterial endotoxins, which are cause necrosis of the retina and inflammation. And you can remove any materials that might have a biofilm, like a nail or biologics, a tooth or something like that, or animal materials or vegetation like cactus spikes. So many advantages. I tend to use both intraocular and peribulbar antibiotics. Again, I defer to Harry Flynn on this, but we tend to use bank intravitreally and assume in these anytime it's a biologic material associated with the trauma or an agricultural type of, or taking care of your lawn or whatever, that sort of environment, or working with animals. Again, we tend to treat it as if they have endophthalmitis, even though there's no evidence, and use intracameral antibiotics at the end of vitrectomy. We've talked a lot about this cryo, but bear in mind one additional issue I didn't discuss. When a foreign body bumps the retina and that area turns white, that will heal on its own. That retinal whitening, if you don't see a discrete retinal break, don't use laser and never use cryo. So if you see a retinal break at a trauma site, just make one row of confluent laser around it, and never apply that before you take out the foreign body. I've seen numerous people, and when I've been a visiting professor and they're showing their surgical videos, that they'll sew a foreign body on the retinal surface without a retinal break, and they make 4 or 5 rows of laser around it, and then take the foreign body out, and now it tears at the laser marks because they've made the retina acutely necrotic. Far better to very carefully and slowly lift up the foreign body, using a second instrument if necessary to make sure you don't lift the retina or tug on it, and then inspect. If there is a definite retinal break, make a single row of confluent laser around it, as opposed to these multiple rows that create more scarring, more PVR, and a scotoma that the patient can visualize. Many foreign bodies sit in the posterior bowl. And patients don't appreciate it if you've made a 5 disc diameter scar in the posterior pole when it could have been a 1 disc diameter scotoma if you hadn't applied excessive laser. Very important to think through that. So let's go to some of the videos now. And so here's a patient that had a double penetrating injury. The entry wound was closed with a running 8/0 nylon. The posterior vitreous cortex was detached from the retinal surface, so it was conical in shape, and that was removed so you couldn't get transvitreal proliferation. But vitreous was in the exit wound, and that was left behind intentionally. Why would you leave that behind? Think of it like omentum in the abdominal cavity. So you get hit in the tummy with a cactus spike, and the omentum plugs that to prevent you from dying. So if vitreous is plugging an exit wound, leave it there. Just trim it flush with this retinal surface. If you pull that plug out of the wound, you'll have a wound leak that you can't get to and repair, and potentially a retinal and iris, it's not iris, excuse me, retina prolapse out that wound. And now you'll have to do excessive retinopexy. If you put silicone oil in the eye, which is often a good thing to do, it may exit through that wound into the orbit. So big mistake. So in short, if vitreous is plugging the exit wound, leave it alone and just remove the vitreous, do a so-called core vitrectomy. Very important point. What's the rationale for vitrectomy with foreign bodies? This is kind of a moot point now, so not so many people use the magnet. But one, you remove vitreous hemorrhage and you remove lens material if necessary, or blood in the anterior chamber if necessary, so you just have better visualization. The problem with the magnet is that you don't know the direction the foreign body is going to fly out of the eye, and now, if you're using a pars plana magnet to pick up the foreign body to then grasp it with forceps because it's laying on the macula, that's fine. But a big magnet, so-called giant magnet, external to the eye, is simply, I don't know the indication for that, and I haven't used one for 40-some years. Another rationale for vitrectomy in the intraocular foreign body setting is the removal of the substrate for subsequent hypocellular vitreous collagen contraction, in other words, PBR, and traction retinal attachment. You've reduced bacterial and fungal burden. That's important. You've reduced any toxic materials. If steel foreign bodies or copper have been there even for 24 hours, often they'll crumble a little bit and there'll be some free iron or free copper product that leads to toxicity. When you pick up the foreign body, you leave that residual material behind, you can clean that up. Obviously, that's the best way to repair any retinal breaks and detachment, not a scleral buckle. So you access the ability to do fluid air exchange, air gas exchange, and particularly silicone oil. And as I've said many, many times, lensectomy and complete forceps-based capsulectomy is very crucial in this setting. These forceps are the best ever. They're unfortunately no longer manufactured. Why did I like them? Because they were diamond coated. John Marie Perel developed these with Grishaber, and you could pick up the largest foreign body and it would slip out of your grip. The max grip forceps from Alcon certainly work quite well. Some of the forceps available today don't open far enough. So when you choose forceps, try to think of ones that have a maximum purchase on these hard surface foreign bodies. Hammering metal on metal produces a foreign body that's tempered steel, and you have to have some diamond coat to penetrate and properly grip that surface, or you have to sort of encompass it with sort of some basket type forceps design that really captures it. So it's not easy, and there's a tendency to make the sclerotomy too small, and as you try to take the foreign body out, it's dislodged from your forceps and falls back in the eye, and then now you've got a leaky sclerotomy. So you've got to make the sclerotomy adequate, and we'll get to that technique in just a minute. If you have a large foreign body, as depicted here, first do as complete a vitrectomy as possible. Eliminate vitreous everywhere. Don't worry about the foreign body falling down to the macula. If you don't grab it, it won't hurt the macula. Just get rid of all the vitreous. Then pick it up with the forceps in whatever orientation it is, get a good grip on it and move it up into the middle of the eye, and then start pulling it toward the pars plana. Only then do you reach down, take the endoilluminator out, the valve cannula will prevent a wound leak through the endoilluminator site, and use a super sharp or a diamond blade and enlarge the wound. So you're kind of pulling on the wound with the shank of the foreign body forceps and then cutting the other way so that you can enlarge the wound then. But I've heard people use an estimate of the size of the foreign body, maybe from preoperative CT imaging. Oh, it's a 9mm foreign body. Let's make a 9mm wound. Don't do that. Grab it, hopefully, so that you're removing it on its long axis. It might be smaller than that. And then don't enlarge the wound any larger than the shaft of the foreign body forceps until you get the foreign body almost at the pars plana. And then you can enlarge the wound. The eye's going to have a big wound leak there. Carefully remove the foreign body and then suture that wound before you go on and do further vitrectomy. If you have a very large foreign body, often the lens is damaged. I don't recommend removing these through the pars plana. I once had a guy that heated up a spark plug and the entire top blew off, and his entire eye was filled with the top of a spark plug. Yet the retina looked in pretty good, and so I made a very large limbal incision, 180 degrees or more. Grabbed the foreign body with the forceps, brought it anteriorly, then made the wound with the other hand, the corneal limbal wound, and then passed this, as you see here, retrograde out through the wound. This is a very effective technique for these types of cases. And viscoelastic or liquid perfluorocarbon is not going to help you in this setting. It's about properly grasping the forceps, the foreign body with the forceps, and then making the wound large enough so you can take it out without traumatizing the corneal endothelium. If there's a foreign body that's been there a week or two because somebody missed it in the emergency room, then you've got to incise the capsule first. Don't just grab it and pull or you'll tear the retina every single time. So I first incise this little capsule around the foreign body with the MBR blade tip. Then I take the scissors and I enlarge that incision I made in the capsulated foreign body. So I enlarge that so the foreign body is kind of loose in there. Then I grab it with the forceps and extract it from the eye like so. And that is far safer than just grabbing it and tugging on it and taking capsule with you and making a big tear in the retina. If you've got a subretinal foreign body, I do not advise cutting down on the sclera and removing it externally. I know others advise that. I advise coming in through the making a retinotomy. Often you can use the original entry site and passing the forceps underneath the retina, bringing the endoilluminator closer as depicted here so you can see what you're doing, and then pull the foreign body out through that site. You can also use the endoilluminator as a second instrument to hold the retina back so you don't lift the retina inadvertently when you're doing this. If you've got a typical electrician injury with a piece of wire as depicted here, they often lay crosswise on the surface of the retina or tangential to the retinal surface. And if you pick them up as depicted on the forceps on your right here, you would have to make a huge wound in order to get it out of the eye. So pick it up with one pair of forceps, use chandelier illumination so that you can be bimanual, take it up near the front of the eye, and then take another forceps and grab it on the end so you can remove it through a very small wound along the long axis of these cylindrical foreign bodies. Far better way to do it. And I've heard people say, well, I don't have 2 pair of forceps. Well, get them. Get another pair. This is the right way to do it. I typically use the Alcon Max Grip forceps these days for this type of approach. Silicone oil is your friend. But what does silicone oil do? It's not this dumb term tamponade that should never been used. What I call it is interfacial surface tension management, interfacial surface tension. So that's what it does. The surface tension of air or gas is 70 dynes per centimeter. The surface tension of oil is 42. Liquid fluorocarbon is about 25. So in short, the surface tension of oil is 50% less. It is only a little bit lighter than balanced salt fluid. So it's not a buoyancy effect. It doesn't press on the retina. It's about surface tension management. For what? Missed breaks or new breaks that occur from PBR or this other point. And that's what I call retinopexy avoidance. I've often seen this, oh, there's a huge wound in the retina. Let's make 4 rows of laser, 3 rows of laser long. No. Just put in oil. Don't do any laser at all. So I often, with retinal necrosis from blunt trauma or in a CMV retinitis situation, I refer to the silicone oil surface tension management benefit as retinopexy avoidance. So you can always, at a later time, when the eye is completely quiet, not inflamed, electively, months later, you can laser the retinal breaks even in the office incrementally, and then wait till they're healed and then take the oil out. But this idea that any defect in the retina, it's a bad case, therefore it requires lots of retinopexy, just the opposite. The more inflamed the eye is, the less you should want to use retinopexy. So please keep this point in mind. It's very, very important. So silicone oil is your friend. It's used more and more in trauma case today. I have no problem with that notion. If you take the lens out, as I said, go ahead and take the capsule out because it'll close the inferior peripheral endectomy you must make to allow aqueous humor access to the anterior chamber and corneal endothelium and prevent pupillary block from the silicone oil. So if you leave the capsule in, it will close that inferior PI over and over again. Big mistake, common mistake. So again, silicone oil is many times for retinopexy avoidance. If you've got trauma, if you've got exit wounds right near the macula, don't laser around that and give the patient a giant scotoma. Simply put in oil and let Mother Nature heal it, and as opposed to this retinopexy in the posterior pole. Well, that's my last talk. Let me go over to the question and answer block here, and I see if somebody has questions they need to be answering. What do I do in Komosho retina, including macula, and not improving? Okay, Komosho retina is a term I don't use. I call it traumatic retinal whitening. Why? It's been shown by Cipollini and others at Bascom Palmer many years ago that with electron microscopy, this is shearing of the photoreceptors. So first of all, so-called Komosho, call it traumatic retinal whitening. It's not edema, and steroids don't help. Simply let it heal. But if there's truly retinal necrosis, I just described the technique of putting oil in and don't do any retinopexy. But when you've got traumatic shearing of photoreceptors from the apical processes, there'll be some repair over weeks and months. There's nothing you can do to facilitate that repair. The main thing you got to do is not to make it worse. So the second question, it's a good one. It says, for a large foreign body, should we open to the limbus even if the lens is intact and clear? I have made a 12 millimeter pars plana incision in this setting. It's very rare to have a huge foreign body and a clear lens. But I think for the most part, the risk of cyclitic membrane and loss of the eye, ultimately to ptosis from very large pars plana incisions is so great that it's still better just go ahead and take the clear lens and remove these huge foreign bodies through the limbus, being careful to protect the corneal endothelium. These trauma eyes, if you require a PK, there's a good chance you're going to get rejection of the corneal transplant. Then the last one says, if instruments of vitrectomy are not available and the foreign body is large, must it be removed by the magnet if it's iron? Well, you don't have any other choice if you don't have vitrectomy instruments. I don't know what else you would do. The problem, if you try to remove a large foreign body with the magnet and you don't do a vitrectomy, show me an eye like that that's ever survived that. I think the answer is you must somehow access vitrectomy technology. So another question, any special tips for glass foreign bodies? Glass obviously has very high Rockwell hardness to the surface, and typical forceps won't grab it. And so if you grab it with most forceps, even if they're serrated, it will fall out as soon as you touch the sclerotomy and you're trying to remove it, or it'll even fall out as you're lifting it. Don't worry about it damaging the retina from falling down in the macula. Worry about it damaging the retina from what you do to try to pick it up. So if you pick up something, think through as your forceps apply force, will it cause this to change position so it snaps down and the glass damages the retinal surface. So the diamond dusted forceps, like I depicted, are absolutely the best way to remove the glass foreign bodies. They're no longer made, but hopefully they will be in the near future. Next question said, should we do vitrectomy in case of vitreous hemorrhage only or conservative treatment? Completely depends on the situation. If you are doing ultrasound and you're convinced that the vitreous is mobile and you're convinced that the retina is normal, sure, you can follow a vitreous hemorrhage for a considerable period of time, months, and let the patient's other issues, well, I can't go back to work because I can only see out of one eye, or my other eye is amblyopic or whatever, make the decision that way. But so you're not required to do a vitrectomy just because there's a vitreous hemorrhage, because vitreous hemorrhages have been removed when they're a year out and still have good retinal function. So another question is, after repair of scleral laceration, what do we do to prevent RD? Well, it's not about cryoing the wounds, and it's not about buckling, as I emphasized in my talk. It's about doing a vitrectomy to prevent vitreous traction causing a retinal attachment, and then using silicone oil in certain cases if there's hemorrhage on the retinal surface and if you can't find a tear. But don't do blind scleral buckling or retinopexy in this setting, and never apply cryo to the scleral laceration site. Next question was, should we do primary repair and lensectomy at the same setting or better separate? If there's any question about your ability to see the vitreous cavity in the retina properly, remove the lens and remove the capsule. It's better to do it at the same setting. And then you've made this one compartment eye that I described earlier is less likely to have produce hypotony and ptosis and cyclitic membranes. So I'd say do it at the same time. Any situation, silicone oil being left in indefinitely. There's two complications of long-term oil if it's high-quality oil. One is emulsification. That's the breakup into small droplets that cause glaucoma, and that is exacerbated by vitreous hemorrhage, by inflammation, and by viscoelastics. There's no difference between the 1,000 and 5,000 centistoke oil. So that's one reason to remove oil if you can. I'll come back to the if you can statement in a moment. The second reason is we didn't know about this until we had OCT, and that is that inflammatory macular edema that's virtually impossible to treat is quite common actually with silicone oil. So in short, I have to remove silicone oil because of this macular edema as soon as I see it on OCT. But there are patients that have you think all the retinal breaks are sealed, you take the oil out and they redetach, and a day later you got to put the oil back in. Everybody that uses oil in cases that really need oil like that, there are some patients that just need oil in forever. And this notion that somehow 5,000 is better than 1,000 is not supported with data. Next question was, what's the best protocol to treat corneal staining in high FEMA? Well, the only thing is if you catch it early, the staining is less. So it's an argument to get rid of the high FEMA early, or you have to do penetrating keratoplasty, but there's no treatment to facilitate the diffusion of iron from free hemoglobin in central cornea to have it diffuse out peripheral cornea. There's no treatment for it. You can't chelate it or anything. It is as it is. Well, we reached about the end of the time period at 8:57 here, and I appreciate all the good questions.